here, and I hope that we're going to have very exciting session. The international experience of response to COVID-19. I would like to give floor to our first speaker, to um, Elena Manushan, the first Deputy Minister of Health, Republic of Armenia. Lessons of combating HIV/AIDS is an example of successful combat against COVID-19 in Armenia. So thank you, dear colleagues, dear participants of the international conference. In the first place, I would like to thank for this opportunity on behalf of the Armenian delegation to participate in the conference on such an important topic on epidemiological well-being. So the pandemic of COVID-19 made adjustment to global healthcare agenda as well as to our agenda in Armenia. So the healthcare system had to respond quickly and provide medical care so that nobody is left out. And here the successful examples and mechanisms of HIV and AIDS fight were helpful, and only radical measures, policies, and the redistribution of resources can help us to be out of that crisis. Some of the learnings from HIV and AIDS pandemic, which we are using to fight against COVID in our country. So the global pandemic should consolidate all of the efforts, including the international community. How we could provide for the life-saving therapy, exchange of information, and the use of international platforms help us to say that after 1 year after the pandemic, we have a life-saving vaccine. So now there are no borders. The works were going on 24/7 by all of the countries. Everybody was helping each other, providing the necessary resource for diagnostics. And I would like to mention here the valuable help of the Russian Federation as well as for another pandemic, HIV/AIDS, and we were, of course, cooperating closely with other colleagues, with the colleagues from WHO, and also we had some targeted efforts which could provide for both medical care and also exclude and mitigate the social economic consequences. In March 2020, we started to face COVID pandemic. That was also important not to miss out another pandemic, which we have been combating for 3 decades. This is HIV space, when we had the limitations for movements, and when the work to prevent HIV was also limited because of the limitation measures, and we needed also to distribute the specialized treatment, and we face certain difficulties, but thanks to very quick response, and also thanks to the new team of our institute and the National Institute of Healthcare, the National Tuberculosis Center, and international donorship organization and support of a non-governmental sector, it was possible to continue prophylaxis for people living with HIV, people who are on replacement therapy, and other key groups of patients. Since the very first days, the following steps were taken to mitigate the situation, and we provide for continuous treatment, and also we had the cooperating NGOs which were distributing the medicines to all of the patients all across the Republic, and understanding the spatial status of the groups under risk. So we distribute information about COVID-19 and the work of NGOs and the Centers for Prevention and Treatment for HIV, AIDS, and Tuberculosis. So also there were psychological care and other types of medical care. We used online services and video conference connection. We used the mobile clinics which were provided by the Russian Federation government under the UNAIDS program for joint prevention and express testing for COVID-19. And other measures were taken related to tuberculosis drugs to supply the anti-tuberculosis drugs during 1 week time. And all of the antiretroviral drugs were supplied within 1 or 2 months. Thanks to tough planning, there was no deficit and no shortage of drugs and no stopping of treatment in the Republic. I would like to emphasize that the potential of HIV center that we achieved over the last 10 years, we used that since the very first day to fight against COVID in our Republic. On top of that, thanks to the needs of a quick response in the context of pandemic of that we were facing, and we also assessed once again the great efforts of UNAIDS, and we started to work to identify the gaps. And also we had a questionnaire all across the Republic. During lockdown, we never had issues for people who are on ARs, and I would like to say that despite we had a very close work between governmental institutions and non-governmental organizations. We did everything to work with HIV, and we understood another learnings from our work with HIV and AIDS. And when we're working against the COVID, we need to be closer to our patients during COVID pandemic. So they were NGOs that used to work with HIV, so they were providing a lot of social support, not only providing for the needs of people who live with HIV and AIDS. And the results are so fragile. It is very important to never stop and move on. The risks of COVID are also slowing down the advancements that we have with the HIV AIDS. We all know that's too soon to say that the pandemic is over, and also we need to assess social economic losses, but at preliminary estimation we understand if we are not actively involved in fight against HIV, we not assess the situation, review it, if we not have additional incremental funds allocated, we may be in a situation when during the pandemic or after the pandemic another pandemic may become a problem. Why I believe this is important to have such discussions, and we need to work in partnership with Russia and with our international partners, UNAIDS and WHO. Today we need solidarity and political will to fight against this crisis together. Thank you for your attention. I wish you health. Thank you, Yelena, for such a great presentation, and you demonstrated many aspects and the relevance of this problem. And we need to pay attention to the most vulnerable groups of patients which suffer from HIV/AIDS. So we have 5 speakers, and the time is very limited. Those who have questions, please ask them in the end of the session. I would like to happy to give floor to MD Professor Alexander Simonov, head of a research institute viral infections from Yekaterinburg, with the very intriguing name of the presentation lesson of COVID-19 pandemic in Italy, because Alexander participated in the events evolving in March and April last year, and he was on that humanitarian mission of the Russian Federation, and in the most affected province in Lombardy. Yes, thank you for such an introduction. I feel just uneasy, but I'm Doctor of Biological Sciences. We are not all of ours medical doctors. Well, this is not a perfect topic for the presentation. We often speak about biological markers, about treatment, about viral stuff, and we need to speak about international experience of fight against the pandemic, what we did in our humanitarian mission, and what the Russian Federation did at the request of the Italian Republic. Natalia is being too modest. If you look at the photo in the corner, so we may see her as well here. So we were together, and as experts from Rospotrebnadzor, and that was interesting experience. And so here I will present my opinion through how I perceive that, through my own experience. That was my first experience. And I just announced my disclaimer, and we could move on. Well, the next slide. The main thesis for this presentation is the following idea. Yes, we do here the new values are not material values, so this is the values are non-material, such as health and the criteria for assessment of life, being satisfied with life. That should include epidemiological safety, well-being. Well-being should be defined as epidemiological well-being. The power of the state is the power of the healthcare system, and it turned out that probably the standard assessment that we used before the pandemic, they do not always work based on absolute numbers, on and also ending with the physiology and ending on with the results of some received by some scientific countries. So Italy is one of the countries which demonstrated the example of outstanding work, and also the same outstanding failures, especially at the onset of the pandemic. It seems like all of the mistakes, possible mistakes, were done by them, and the situation got out of control. And also there were 4 groups of countries based on the response of the countries to COVID. So the first are independent countries who were eager to provide for themselves and for their citizens, and they could fight against the pandemic. So of course this is China, this is Korea, and the Russian Federation. The second group, well, they are developed countries who nevertheless could not by themselves cope with the pandemic and had to ask for help from the countries which have that opportunity, and also we could have here Kyrgyzstan, Kazakhstan, Tajikistan, but still Italy was asking for help despite such a difference in GDP and per capita income. So they were in the same group, and there are several reasons for that. And the third group, these were the extreme states, so which were just not accepting that there was a pandemic, like Sweden. And of course, now this approach seems very wrong. This is the approach we should avoid. The fourth group is the most arguable. Well, these countries, they seem to provide for themselves. They are manufacturing the vaccines, and they also have the beds available, but the total number of mortalities and of infections is high. The US, UK, France, Belgium, the Netherlands, and some other countries. And they are developed countries, and they're independent, but the pandemic there was like huge. It was grandiose. So why Italy, which is among the leading economies of the world, and is very well equipped in terms of the hospitals, and also they have medical provisions, equipment. They are in the second group. They have to ask for help, and this is still something I don't know, but we will try to say something about that, about the reasons for this happens. A little bit of history. The first case was registered 443 days ago, on the 31st of January 2020. Well, and as you remember from yesterday, our first case was on the 1st of March, and here in the 31st of January, now 3,900,000 cases and 115,000 deaths. It was 3-4 days ago, and the number is growing. And Italian Republic has all of the chances to be ahead of Russia in absolute numbers. As you understand, the population is much smaller. And in all of the regions, they have coronavirus cases. And also the regions with worse cases, so these are Lombardy and Veneto, the most affected, and these are the main industrial regions, so this is the industrial heart and the touristic area, so banking industry. And the richest population, and then Campania is the most affected. It's in the south of Italy, which is underdeveloped relatively, and it is densely populated and quite poor. And also we see the same results in the richest and the poorest regions. This is an interesting detail about Italy. Seems like it was all starting well, and they closed air flights with China.
But that is where it stopped, and the restriction measures were not introduced for a long time. They started registering first cases of infections, but they did not take adequate measures on time regarding introducing certain restrictions, let alone quarantine. We're just talking about mild restrictions that would cover the country. So they started limiting the movement of citizens in so-called red regions where the incidence was the highest. And at the same time, it was not done instantaneously. Instead, they would say that, okay, in a week we are going to stop moving around in that or the other region, given the fact that the incidence is going up. And what does the population do? They just jump into their automobiles and rush to other regions where still there is work. And then there is another message on the part of the government that the incidence is growing in yet another region and it is going to be closed in a week or so. So instead of containing the virus spread, they just spread it around, and we saw that the incidence in Bergamo, Venice, where traffic was really high, was going up very quickly, and instead of closing the region, they started ousting out citizens. And we know that people from poorer regions come to the north of Italy to work, and these people, as they heard of the government plans to close the regions, they decided to go back home to the south. And as a result, within 3 weeks' time, the infection spread across the whole country, including the most remote areas. So the wave of labor migrants went back home, and that is when incidence was registered in each and every region. Moreover, interestingly enough, Italy needed assistance because it turned out that due to certain reasons, the Italian Republic saw certain gaps in healthcare sector, in education sector, so they lacked experts in epidemiology, in hospital epidemiology, because these professions within the healthcare system are not of first priority, and training of experts in these areas were scaled down. And we know that in some Italian universities, epidemiology was not a mandatory subject, so the students would quickly take a basic course about epidemiology and biosecurity, and it was not a serious subject, and that would imply practical lessons, practical classes. And that has been true since 1996. Why so? Because incidence of certain infectious diseases was sporadic and outbreaks were minor, and typical epidemiologists would focus on virus, hepatitis, AIDS, and so on. But the country has not seen large-scale pandemics, and therefore the knowledge in this area was not spread around the entire medical community, and advanced training courses would not include this subject. Well, we were surprised about that, and we would ask our Italian counterparts again and again why this actually happened. Well, they would tell us that pandemics was not really a hard case. Yes, there is the Institute Superiore, but again, this is just one facility that is supposed to cover the entire country. Can I see my next slide, please? So besides the organizational matters, there were also political reasons, and we all know that any successful endeavor when it comes to fighting the pandemic requires mobilizing society at all levels, and certainly there should be political will in place, and politicians should demonstrate the willingness to counteract outbreak, no matter how unpopular the measures would be. While Italy demonstrated confusion when it came to introducing restricting measures on the part of the government, when it was high time to introduce limiting measures, when it was high time to cancel events that did not happen instantaneously. So football matches were not cancelled, although incidents had been registered for 20 years, especially in Milano, where the incidence was the highest, and that was the hotbed of the infection. Well, you know that football is almost like a religion in Italy, and there was an important match between Juventus and Roma football clubs, and that brought together thousands of fans that came from all over the country. And you know, the decision on canceling Venetian Carnival also was quite belated. We understand that economically it's a very important event, but if we look at the incidence and its growth, we understand how quickly the wave of the pandemic would spread, and that again enhances the fact that the interaction between the medical community and government should be not based on recommendations. It should not look like the following: why don't we close the festival? Well, let's do it in 2 days. Let's still let people enjoy their high sales. Well, when it was finally clear that the situation was way out of control, and indeed the incidence was horrific, and the increase of infected cases was just overwhelming, and you remember that last year we were reiterating again and again that it was very important for us not to let same situation happen. And we understand that when all infected people spread the virus from Lombardy across the whole country, look, you see, I saw Colosseum without a single tourist. There are very few people who can both having the same picture when you can walk around Rome, and it was completely empty. I remember together with our military guys, we were going to our point of location, and we were allowed to stop for 1 minute and take those pictures. An unprecedented event happened against that terrible background. The Italian government allowed the arrival of Russian military doctors, our emergency medical professionals, our epidemiologists, and others, and they carried out anti-epidemiological measures, and they worked in the region that was hit the hardest. That is the city of Bergamo. Next slide, please. So we were able to streamline the process of PCR diagnostics. We validated Russian tests together with our Italian colleagues. We also conducted the trainings on infectious control, on following up the patients, also training on disinfecting measures. By the way, similar trainings had not been conducted before, what really made us feel very surprised. And here you see we were dividing the hospital into zones, and this hospital was organized de novo in the Expo Center of Bergamo. And once it was rolled out and launched, our experts together with Italian colleagues started working there together, and that was unprecedented experience, and we shared all our best practices. And we know that by that time 70% of medical personnel of Italy got infected. There were 0 cases among the Russian counterparts. And that again is telling about our practice and tradition of infectious control. We know that Italy was close to putting an end to pandemic in its territory, but it did not finish because restricted measures were lifted, and now they have the incidence that is even high. That at the initial stage, of course, a shortage of personnel is still a large problem, and we know that still there is strong anti-vaccination lobby that is supported by the Roman Catholic Church, and there is some tension between the medical community and the lobby with engagement of mass media and politicians. So here you see what happened after lifting quarantine, and you see from almost 0 mortality cases, we would see the sharp increase. And as for vaccination trainings or vaccination program, we know that it is based on the European Union approach. So you have to be registered for vaccination as a member, as a citizen of European Union, and you can be in line number 32 million. Can you imagine that? And that is unprecedented for Russian Federation, although, of course, the speed is accelerating and popularity of vaccination certainly is high, but people still have to wait in line and have as many as 32 million people in front of you. And, of course, Italian colleagues paid attention to our practice, and they understand that thrombosis treatment in regard of treating coronavirus infection is very important. And well, in April and March 2020, Italians already actively use schemes to block so-called cytokine storm. Okay, the click is working. I understand that I'm out of time. I should say, wrapping up, that we certainly make very important and serious conclusions. And, well, conclusions are on the slide. I don't have to read them for you. You can do it yourselves. But seriously speaking, this experience of international cooperation demonstrated once again that when professional medical matters are of high importance than the political ones, then despite all tension between the countries, you can succeed. And Russian military doctors, together with Italian doctors, can work very well, very efficiently, and can learn so much from each other. And I hope that we will have a larger number of projects of this nature even when the pandemic will end. Thank you very much for your attention. Well, dear Alexander, thank you for this exciting journey into the events that took place a year ago in Italy. And it was an assistant, but also great experience for us, because in the Russian Federation, we had very few cases of registered cases of coronavirus infection, and the experience of rolling up mobile hospitals on the territory of, let's say, export centers or large vacant facilities like it happened in Bergamo was instrumental. And Italians were the first who started talking about thrombosis, absolutely, because Lombardy has a very high percentage of senior population, and they had lots of patients in senior facilities, and you see many people in Europe very often upon their retirement move to Italy because the climate there is so favorable. So we didn't have that percentage of pensioners among our patients, but they did. Yes, absolutely. And the therapy with the use of anticoagulants was included in our protocols as well. And we took a different approach on using hormones, because prior to that, hormone therapy was not recommended for treating COVID. Well, once again, thank you very much. We will let you go. And now we would like to hear a message from another member, that is the head of the mission of Rospotrebnadzor of COVID, that is from Uzbekistan, and I give the floor to Doctor of Medicine Tatiana Zemtsova, who is the deputy head in medical area working in the institute named after Gabrichevsky. Hello, dear colleagues. Indeed, interaction and cooperation with other countries is instrumental and invaluable for us, because it's not only us who are ready to share all our data, all our best practices in order to provide help to our colleagues overseas, but we also, in our turn, learn so much, and that is what we really need very much. Every time when I have a business trip, I saw different objectives. And working in Uzbekistan, we were tasked with solving an issue of treating very severe cases. So when we got an inquiry from the Ministry of Health of Uzbekistan, we saw a high number of severe cases, a great number of patients that had repeat hospitalizations, hospital admissions, and that meant that hospitals had 100% occupancy, and emergency aid units were extended by 100% in terms of their capacity. So if typically they would have 8 to 9 people, they would house 16 to 18 people, and still this was not enough. And artificial ventilation units were not sufficient for the Republic, and the situation was very challenging. We composed a delegation for the business trip that included the experts from a Russian surveillance agency from Moscow, St. Petersburg, Volgograd, that also included experts from the Ministry of Health, and it even included counterparts from other countries like China and Germany. So we wanted to understand what was the reason for such severe courses of disease among such a great number of patients. So we worked at 7 hospitals in Tashkent region, Samarkand and Samarkand region. We also analyzed activities of medical professionals in outpatient clinics. We analyzed work at the labs in the Republic of Uzbekistan. We were actively engaged with our counterparts in the Ministry of Health of Uzbekistan and with the Embassy of the Russian Federation. We analyzed all admission work in all admission units for COVID patients in Tashkent and Samarkand, and focused on treating and following up patients with severe course of the disease. So again, we analyzed the reasons for such severe course, and we had detailed talks with all the doctors and looked on one hand on shortcomings in diagnostics that would cause the spread of the disease, and that would exacerbate the course. And we also looked at efficient ways of using the equipment, because after all, when using artificial ventilation units are associated with certain specifics, and we understand that improper use of those pieces of equipment may cause certain bad conditions. So we held 8 conferences and passed our recommendations and conclusions that indeed were quite general on one hand, but we understood that recommendations were specific for each unit, and we held meetings and discussions for every single facility in order to increase the understanding of the situation in the Republic. One of our proposals that was the following, that is to carry out auscultation without wireless phonendoscopes, and that would help to diagnose developing complications like pneumonia or arrhythmia, myocarditis, and that would be possible without using additional equipment, because we understood that the new facilities were short of equipment, even the ones to carry out ECG, let alone computer tomography. And this method allows to carry out differential diagnostics very quickly, and it's not time consuming. It does not require moving around of the patient. It can also prevent the risk of infection for the medical personnel and for other patients. So that means that you don't have to move that patient around. So every doctor that we saw received information about measures of personal protection that was very important from our point of view, and we saw core reasons that would cause such a large number of severe cases. And what did we identify in this regard? We have identified core reasons that would substantiate the spread of disease and would provoke the severe course. So first of all, that is not timely or improper diagnostics. So we understood that the quarantine measures were followed only within 10 days, and the lab diagnostic was carried out way too early after the contact, what certainly was one of the reasons for spreading the disease. Because if you analyze the biomaterial on the 5th or the 8th day, so that you could receive the result by the end of the 10th day, we understood that at this stage, certain patients would not demonstrate signs of disease, while others would not have any symptoms, and the incubation period could last longer than 10 days, and then the transmission of the disease would take place after the 10th day, when the quarantine measures for a certain patient would be lifted, but this patient would contact a large number of people and contract others. So we recommended that the isolation would be extended up to 14 days, and the lab diagnostics would take place at later stages in order not to miss out any cases. Of course, a large problem at that point was in the following. Many patients would go to admission units without PCR positive result, and they would have different pathologies like like congestive pneumonia or other infectious diseases, and they would not be isolated from COVID patients. They would stay together with all COVID patients, and would we understand that the air in the hospital would not be treated, and then the patients without COVID would develop COVID as well, COVID triggered pneumonia, and that certainly would imply very severe course of disease. And the patients without negative PCR diagnostic, of course, would have to stay in the hospital, and we understand, on the other hand, the traffic in hospitals was so high, the doctors would be forced to discharge patients even without PCR test, and that certainly would contribute to spreading out infection further on. And actually, these patients would be re-hospitalized and would add to the workload, to the burden the hospitals already suffered from. We also understood that many doctors did not have any means for personal protection, and some doctors that underwent COVID would ignore the recommendations to use protective measures. And we understood that even if they would not develop the disease again, they certainly could transmit the disease, and certainly it could be another contributing factor for increasing the incidence. And also there were quite many contradictions or non-substantiated approaches to therapy. So we saw wrong use of improper use of anticoagulants, antiviral medicines, etc. And this is another area where we provided our recommendations. And what results did we receive? Well, the largest or most significant result that demonstrates the efficiency of our work, and I would like to emphasize that again, this result is based on contribution of many colleagues of ours, including those working for health, Ministry of Health and other agencies. So the largest result was that the number of infected people went dramatically down, and that meant that even newly opened hospitals, except for one, could be closed. So this situation was under the control, and we should say that we still keep in touch with our colleagues, and again, we can see the results from introducing the measures, and here with arrows you can see when we were engaged, and you see the decrease in the number of infected people. But we understand that at that particular point there was a shortage of personnel. Then there was another increase in September, and that is when additional diagnostic measures were introduced, and then following that you can see an obvious decrease, and at that point, when many countries saw dramatic increase in incidence, that is October, November, and December 2020, the educational facilities in Uzbekistan could continue working. Many shops, stores were open, and restrictions were not significant, and the mortality rate was also quite low. Of course, we have done a great deal of work, and the recommendations that were introduced, of course, have to be adjusted individually when it comes to their use in each and every hospital. We still hold joint conferences online. We analyze severe cases. We analyze new approaches when it comes to treating patients with COVID-19. And of course, in my opinion, we worked with many colleagues in different countries.
And according to such experience, when we have close communication and cooperation, when we are talking and discussing all of the problems, when we introduce the objective and effective events and activities, so we can successfully control the spread of COVID-19. Thank you for your attention. So, dear Tatiana, thank you for such an interesting presentation. And the most important thing is the transfer of the Russian experience and in care for the patients and for diagnostics is continuing until now. And I think you will also provide support for them in the future. Now, our next presentation, which will be done by Esmira Amamedova from the Republic of Azerbaijan. Experience and less of HIV test and treatment during COVID-19 pandemic. Dr. Esmira. Good afternoon, dear colleagues and dear participants of the conference. To our great regret, we could not participate personally in the conference, but over this year we just got used to being online, to communicate online. In the first place, I would like to thank the organizers of the conference for the invitation to share our experience, how we fought against the pandemic, what were our lessons learned. And we had to go through serious challenges because COVID had a negative impact on all of the spheres of life, economy, labor, education. But despite the crisis due to the pandemic, the efficient ways how to solve these problems were found, and this is what I would like to speak about. Well, introduction about epidemiological situation in our country. For HIV, the estimated number is 60,000 people, users of drug, men having sex with men, 24,000, and sex workers 32,000, and in prison 18,000, which positive 8,688. Out of them, 96%, almost 8,395 are citizens of our country, and 1,093 died, and the prevalence of HIV per 100,000 is 5.2. Which testing? HIV testing is one of the priorities of our national health care program and the program for the fight against HIV. And we have a centralized tender and our healthcare ministries procuring the tests, which are given away in the future for free to provide testing in 48 stations and in 12 mobile stations. All of the labs in the country, every year they give information about the number of tests to HIV center, and this information is accumulated there, and it's further on given to the Ministry of Healthcare. And the analysis of the total number of cases demonstrates that compared to 2019, the number of tests decreased by 22%, sorry, and also we have the same number of new cases like in 2016. The most critical were April, May, July, and November 2020, when the number of tests decreased by more than 2.2 times. And I would like to share our positive cases as well. The number of tests for TB patients, it is increasing and amounted to 119%, and there should be some explanation for that. The colleagues from anti-TB having a long-term experience of testing of HIV for TB, and it gave its positive results. So the total rate is stable compared to 2019, but the decrease in number of tests we did not see. Another important aspect of our work is epidemiological survey for HIV. Before end of March, in Q1, everything was as expected, and the number of cases in March compared to 2019 was higher, and it was 114%. And in April, there was a decrease 42-43%. In May. In July, there was a decrease by 71%. And it's all logical, and we needed around 4 months to come back to normal work, and in August we came back to pre-COVID numbers, and there is a decrease by 25% in the number of cases, and then by end of the year we had certain improvement, and the decrease was by 22%. What was the reason for such a situation? So, no readiness for the pandemic. The fear among the medical workers and absence of experience working in emergency situation, limitations of movement because of the quarantine measures, and almost all of the healthcare institutions and hospitals were working only with COVID patients, and also the outreach services were added upon. As for ART therapy, antiretroviral therapy, so that's not so bad. In the Q1, Q2, when we had that situation with the lockdown and with the limitations, in Q4 we managed to change that situation, and the number was decreased by 17%. As for the coronavirus pandemic in the country, the first case was in the end of February, and the first death was in March 2020. And most of the cases were imported and started from April. So the local transmission of infection was present. In March and April, we still had illusions that that was temporary and very soon it's going to be over and there won't be such a spread of COVID pandemic, though it did not happen. And because of COVID pandemic, there were limitations introduced on top of the quarantine, the lockdowns, and it caused the limitations in movement, and the most affected regions were blocked, and also the module type hospitals were opened, and all of the doctors, including infectionist doctors, were used for COVID, and we faced the following challenge as a result: a sharp decrease in screening tests for COVID, impairment in the work of most stations of testing, and also the main hospitals, central hospitals, they were used for COVID, and over 50% of the preventative stations and also HIV points, so they were not operating, and 6 ART centers were created. They were covering most of the regions, and all of the infectionist doctors, they were working in the hospitals with COVID patients. Also there was a danger that our patients with HIV/AIDS, so they may face the danger of shortages of supplies with ART drugs, and also there could be deviations in the monitoring system of treatment. And since 2014, we had the replacement therapy with methadone. We were also facing the problems with access to methadone. What was done finally? And we had to quickly adapt the prevention and treatment services. And also, of course, we made some awareness campaigns, and we introduced the online consultation awareness for outreach workers, and also for those who work with life-threatening conditions. So the info materials and brochures were prepared. They were given away to all of the NGOs which were doing the work. And also most of the non-NGOs, they had no experience of working in emergency situations. So we had to do HR training on infectious control and safety. We received the special documents, certificates to provide for their movement in the country. Also, we had to prevent accumulation of a lot of people in the station, and the mobile brigades which worked with the key groups of the population, they were also involved in delivery of medicines at home, monitoring of treatment, together with testing and informing, and also the instructions on ART treatment, they were reviewed and changed. So we introduced home delivery, and with the help of other patients, even from one village to another, you could not travel. And the ART were delivered on time in complete volume. And for the third year in our country, we are ordering and procuring ART with the help of UNDP, and all of the logistic issues were solved timely. And if in 2019 the number of patients which had the drugs for 6 months, so it was only 3% in 2020. So this number, at the end of the year, achieved almost 20%. As in June, the guidelines on ART were changed. If before that we would take into account only how long the patient was on ART, and if the patient mentioned that this is a labor migrant and he had to move out of the country, so only because of that he could receive it for 6 months, to avoid stopping the treatment, to have timely medication to avoid the COVID risks. The patients were provided with the medicines from 3 to 6 months worth stock, and they used our regional labs for delivery and other means. So in this slide you may see how the delivery was performed to the patients. So how we were given that all of the documents were filed, and this is how we avoided the risk of COVID transmission to people with HIV. Dear Smira, we are about to finish our session. Please round up. In the end of my presentation, I would like to say that our experience which we received during the pandemic about that, it is important to use the practices that we acquired in 2020, how we managed to avoid any negative impact on incidence of HIV. We need the new methodology for fight against HIV in COVID pandemic conditions or in conditions of having another infection. We need to also train the quick response team to expand the services online and introduce testing for the key groups for HIV, target groups, and for COVID as well. And we received several calls. We'll do the testing of the main target groups, not only for HIV but also for COVID. Thank you for your attention. I wish you to be healthy and successful. Thank you very much for such an interesting presentation. You can see that in Azerbaijan there were some difficulties like in other countries, and as far as I understand, you managed to overcome those problems, and also you restored the level of medical care to our patients. Now I would like to give floor to Maria Shibaeva, senior specialist of intellectual property ITPC Russia. The presentation is called "Reforms in the Field of Intellectual Property Aim to Improve Access to Drugs During the COVID-19 Pandemic." Dear speaker, please not exceed your limit because we are supposed to be finishing.
Хотела бы поблагодарить
And I would like to thank the organizers for the invitation to speak at the conference. Our presentation will be about reforms in IP aimed at improvement of access to drugs during COVID pandemic. As with the spread of the new COVID infection, and also so there were some shortage of drug provision, so we had to accelerate the innovations in medicines and vaccines to expand production to procure all of the necessary medical products. And at that time what started to be actively started, so the well-known medicines, so for other diseases, including HIV, hepatitis C, and they demonstrated certain efficacy for COVID-19. And some of those medicines were protected by the patent. What prevented this global distribution of medicine? International legislation can use provide the opportunity for the use of medicine without being owner of the patent, but some shortages in legislation about unpatented medicines in emergency situation prevented them from doing so. And one of the barriers in terms of access to medicines was a shortage or absence of experience in the use of TRIPS flexible regulations, and also related to licenses and licensing, obligatory licenses, forced licenses, and without the authorization of a patent owner is completely legitimate. They are described in the trade agreements, and one of the first countries to respond by legislational change was Canada, and so the law on the emergency response to COVID was issued. Healthcare ministry, according to that law, can give the permission to use medicines or medical products without the consent of patent owner. The same was done by Germany. They made amendments to the law on prevention of infectious diseases and fight and treatment of this disease. France added an article to the Code of Public Health Care. The Prime Minister can take any measures to provide for the necessary medicines to the population. And in Chile, and there was the declaration adopted, special resolution
that said that the global coronavirus pandemic would substantiate the use of mandatory licensing, and the European Union did not stay aside, and they have developed the plan of action for intellectual property, and one of the goals for that action plan was to remove barriers for introducing generics in the market. Also, in October 2020, two countries, India and South Africa, asked WTO to suspend the action of 4 sections of TRIPS agreement related to the intellectual property, industrial samples, patents, and the protection of confidential information. And Russia also demonstrated certain dynamics in terms of developing legislation. In early 2020, the State Duma has introduced a draft law and changes for the civil code of the Russian Federation that said that the Russian Federation government can provide approval for developing the medicine in the interests of the life protection of the citizens. And that approval would cover the use of inventions, and this law is applicable for the healthcare sector. Beside legislative initiatives, 2020 was associated with 3 mandatory licenses issued for COVID-19 medicines. So in March 2020, Israel issued mandatory license for Lapidavir and Ritonavir. It's demonstrated efficiency for treating COVID, but one company, the patent owner, did not have sufficient capacity, so the Minister of Health provided the approval for important generics, thus providing sufficient number of volume of medicine for the citizens of the country. In late 2020, Hungary issued a mandatory license for use of remdesivir, and Russia in December 2020 also saw the issue of a directive from the government of Russian Federation to use remdesivir without the consent of the patent owner. And in summer 2020, when remdesivir was believed to be efficient, the United States bought the entire stock of that medicine, and at the same time, in order to provide the access to this medicine, the patent owner Gilead provided access to all countries except Russia, and therefore Russian Federation did not have opportunity to use either branded medicine or use generics, and therefore the government just granted the approval to Pharmacintas company to manufacture this medicine. And besides mandatory licensing, there is also such a phenomenon as freewill licensing, and in 2021 Russia has concluded a number of agreements with more than 10 countries and would allow to manufacture our vaccine Sputnik V. Now we are providing the transfer of technology, what means that these 10 countries will start manufacturing the vaccine our vaccine in the very near future. And looking up at our core conclusions, we can see that some countries have changed the legislation so that they would be able to use a mechanism of mandatory licensing efficiently. The Russian Federation has implemented a complex approach that is promoting the draft law, and also it has granted approval to use remdesivir without the consent of patent owner, and also has concluded license agreement for manufacturing Sputnik V. And I also would like to pay your attention to the fact that following use of flexible terms for trips is important not only for COVID pandemic, but also for treating such diseases as HIV, hepatitis C, tuberculosis, etc., etc. Thank you very much for your interesting report. Indeed, the question of licensing and using the medicines that are not registered yet in this or the other country of great relevance, especially against the background of pandemic, especially when it is necessary to make quick decisions. And I think it was the first time in the history of our country when we had to make those expedited decisions. And we are moving on to the last report, and I'd like to give the floor to Izaldi Dumova, who is the coordinator of a program she's from Kazakhstan, and she will talk about the role of multisectoral body in developing and implementing program on softening the repercussions of COVID-19 for patients with TB and HIV. Dear participants, I'm very happy to welcome you all at this conference. Allow me to highlight the role of multisectoral body that coordinates all the processes related to HIV, tuberculosis treatment, and also softening repercussions of COVID within the past year. Kazakhstan, like other Central Asian countries, still holds to their commitment in counteracting HIV and tuberculosis. Here you see the list of declarations that are the driving agent for all our endeavors. Of course, the list is far larger and is supplemented with all the decrees that are taken by the government in order to achieve all results and goals. Proper coordination matters, so coordination of all operations according to the plans. That includes coordination for preparing national reports on progress, the inquiries for financing, and so on. And of course, here you need to have authorities that allow you to do a review at high level. The coordinating body provides a multi-sectoral approach and partnership. The coordinating body includes representatives from ministries and agencies that work with specific categories of population, committees on religious issues, parliamentary platforms, and a multi-sectoral approach is provided with the participation of representatives from all agencies at high level. And also it is very important to have a proper structure in place. What do you need to have in place? Authorities to remove all the gaps and make joint decisions. We also need to have factors of impact on different ministries and agencies. And here you need to have an authority to exercise surveillance and control in terms of following, monitoring political commitments. And you need to have proper human resources available to provide for sustainability and functionality. Here you see the example from Kazakhstan, where the country coordination committee works with the approval of the Minister of Health. And here you see that the coordinating body has representatives from 8 segments, and all representatives are from high level. And here you also see representatives from NGOs, from some financial organizations, international organizations such as Women Living with HIV, with TB, and so on. And of course, we follow the strategy of gender equality as one of the goals of sustainable development. And as for the organizational structure, the head of the is the Ministry of Health. Deputy is the representative of international organization. In our case, this is a representative working at UNAIDS, and second deputy is a representative from NGO, from the agency that works with people that take injection drugs. And the surveillance committee develops the programs and plans. Not long ago, we have established a group for developing projects to alleviate ramifications from COVID, and the main executive body is surveillance committee that oversees the execution of all projects, and during the restrictive measures, the key role to support coordination between and communication between NGOs and other agencies was played by the surveillance committee, and it was instrumental in providing the medicines for all patients and identifying gaps in cases when some regions suffered from delays in delivering products. We are talking about opioid replacement therapy. So the committee informs the relevant bodies and helps in organizing the shipments and helps in removing barriers, and that way we were able to stick to our commitment.
And also, we cooperate with the national programs for HIV and TB, and with the local executive bodies, which are responsible for TB and HIV projects in the region. And we put together all of our efforts to provide for maximum coverage. We identify the needs and also work together to achieve the results. And the representation of different sectors and more clear proportion can prevent a less efficient decision of multi-sectoral or body and eliminate the domination of one and the same group in discussions. Representative of the key population groups and people affected by the disease, so they have more chances here to be heard by the decision makers. And absence of the mutual understanding between the members of the multi-sectoral body and the impact of organization, the conflict of interest also prevents for efficient decision, and the ethical code is important. And the reliable independent secretariat is more important here, and also the financing by the independent sector is more important, so the decisions are really independent. And also sometimes we have unexpected journey, and the multi-sectoral body is at the same time sustainable and adaptable, and multi-sectoral body may be decisive for the success of the programs. That is sustainability. This is the most important mechanism for inclusive decisions. Thank you very much. That's it. Result D. Thank you for such interesting and relevant presentation. Conditions of the pandemic, the structure which provides for coordination between the sectors is important, very important, and the fate of different projects depends on that. Thank you for being with us. And as we exceed our time limit, I have a suggestion. Those who have questions, you may just approach our speakers and ask them. Thank you. Thank you for your attention. All the best.
Добрый день.
Good afternoon, dear colleagues. Good afternoon, dear friends. In the first place, I would like to welcome everybody here, and I would like to welcome those who are near their PCs. And I would like to say that myself and my co-chairs, my dear colleagues, at our session, Tsiganova Елена, chief expert for HIV in the Central Region, and deputy chief infectious doctor, head of the scientific clinical department of Moscow AIDS Center, Department of Health of Moscow, and also represented from Kyrgyzstan. Your name and patronymic, please. I fear I may not just pronounce that properly. Nuria Burdushanovna de Kyrgyzstan. Thank you. Then we are just starting our session. Well, I will just introduce myself. And Mikhail, head of Laboratory of Viral Hepatitis of the Research Institute of Vaccines and Serums, named after Michnikov. I will speak about the actual of diagnostic, treatment, prevention of viral hepatitis in Russia, and we will present some of the new information. And in this limited time, we will speak about 5 major types of hepatitis and the results that we have. In the first place, I should say we all know that viral hepatitis are the typical situations when we see only the cap of the iceberg. So this is only acute condition, and the biggest number of people in Russia, 6 million, with chronic hepatitis B and C, and the viral hepatitis, they have a descending trend. In 2020, we had the record low numbers for the whole history of records, and there was a role of COVID in all of that. Let us start from hepatitis A. Well, the problem of hepatitis A is still relevant. All of the hepatitis are relevant for the planet and for Russia. And it is very important here that, like for other hepatitis, we have a decrease in incidence in almost all regions of the country. And the spread of hepatitis R, they have still seasonality and also variations in the country. And mainly it is typical for children's population, 1.5 in Russia as an average, and there are regions, and there are 6 regions where the incidence is higher compared to all Russia, and in Bryansk region, so as 116.33 among children. So that was the prevalence, and of course here I would like to present our experience. So when we used into one-time vaccination of children, we vaccinated over 40,000 children at the age from 2 till 16. And this one-time vaccination dramatically decreased incidence. And before that, the incidence was 242 and 7.7 in this age group. and there are no cases of acute hepatitis R in the Republic recently. And it is interesting to analyze the post-vaccination antibodies, and if after the first injection, 1 month after the first injection of anti-hepatitis vaccine, and that was a high number, 98%, then in 5 years time it is around 91%, which is quite a high level, and that's not clear why the titers of antibodies increased after 5 years. We should study this, and we are following the situation. One dosage of the vaccine for children decreases incidence not only among children but among adults as well. That could be used in other regions with high incidence of hepatitis and hepatitis E. So I would like to speak about that. It was discovered 40 years ago by Mr. Bulayanov. So this is the hepatitis with outbreaks in the south, in Uzbekistan and Tajikistan. For a long time it was believed that Russia and the countries with moderate climates, they do not have this problem, and there were fundamental studies according to which hepatitis E, its source are animals, in particular mainly these are pigs, and the interest is very high both in Europe and our country. In our country we have a low incidence, less than 100 last year, and in Germany up to 50,000 people with acute hepatitis E. And another interesting thing which changes our opinion about that infection, there are neurological manifestations, non-liver ones, non-hepatic ones, and chronic cases of hepatitis E, which was not typical for hepatitis A, and there are lots of questions here. I would like to present the first case of chronic hepatitis E in Russia in a young person with Beckett's lymphoma. And in 2020 he had RNA of hepatitis E, and the enzymes were high, and with the RNA, so in fecals and in blood serum, you may see it here, and he had the chronic hepatitis. We treated him with ribavirin 800 milligrams per day orally, and the result was quite good, and the RNA of hepatitis E was both in fecals, and then in January we just did not find it anywhere, and now in the world there are up to 6 mutations of RNA of hepatitis E virus which are resistant to ribavirin, and we analyzed, we did the complete genomic sequencing, and when we looked at the first serums in August 2020, we found only 2 mutations related to ribavirin resistance, and there was a gradual increase in number of the mutations, and
несколько мутаций, 4 из 7.
There were 6 out of 7 mutations that we found him. Despite that, ribavirin treatment was very important. I think when you work with chronic hepatitis of unclear origin, we should take into account that that could be hepatitis E, and despite such mutations, you can have a positive result. And of course, we are going to watch him for more time, but for now the results are good. And hepatitis B. And hepatitis B, it's one of the most mysterious hepatitis. It seems like we know everything about that hepatitis, but still there are no secure ways to get rid of integrated hepatitis DNA, and there are cases of hepatitis B transmission ongoing. And the main factors which helps to fight against hepatitis B is the presence of vaccine, its availability. In Russia, we had the program called Health, and many people were vaccinated. In 2019, there was a total of 10 million people vaccinated against hepatitis B, but unfortunately, in 2020, the vaccination rate against hepatitis B went down, which is sad, and we should pay special attention to that, so that the pandemic doesn't have any impact on hepatitis B, because the consequences of hepatitis B are very unpleasant. And one more thing I would like to draw attention to, one of the factors to fight against hepatitis B is vaccination of the newborns, and we need to vaccinate in the first 24 hours, and up to 1 year there should be more than 90% of children vaccinated. These are 3 times vaccinations. The analysis is done before 1 year of age. If we see that in this period the percentage of vaccination is high, from 90 to 99%, the second dosage is used not always. In this period, children are less protected from hepatitis B compared to timely vaccination. We must do that. Another question which is being discussed for coronavirus as well, and the examples of hepatitis B are given on the mutant variants of hepatitis B, which can not be protected by the traditional vaccines. And here we make an analysis of the most pandemic regions, and in Republic of Sakha we did not find the number of mutant forms in this region. The next hepatitis related to hepatitis B, it's hepatitis D without B, delta or D cannot exist. It is very important to watch out for this type of hepatitis in hyperendemic regions. We work in Tuva and in Sakha, and this is interesting that dynamic follow-up for the people who have the antibodies to delta antigen. In Sakha Republic, the frequency of D incidence decreased, and in Tuva it's at a high level. It's around 38-39% among HBS, and we find these RNAs and DNAs. I really like that slide. Here you can see that the incidence of delta in children and adults of the age of 20-29, and thanks to vaccination, that because hepatitis B vaccination is also eliminating hepatitis D. And then the timeline is very interesting. After phylogenetic analysis, after making such trees with the time scales in Tiva, hepatitis B was for 2000 years, and delta is a new infection. It came there only 60 years ago, and there is a chance that hepatitis D may enter other republics. One of the hotspots in our country is Dagestan, with the wide spread of delta infection. And also hepatitis C, we all know how serious it is, but the results that we have and receive with the help of new drugs. So the give wonderful, surprising results and give ours efficacy about 98% from treatment. And today we are going to have the presentation by Dr. Filanov about the progress on elimination of hepatitis C, and we focus on these 2% that do not respond to treatment. And here the incidence and the range of important polymorphism in resistance-associated substitution RAS, and also the goal was to assess the factors promoting its spread. It is well known that there is association of mutations R70QH in core protein of hepatitis C, and it is associated with 1B type, and over half of virus C infected, they have this genotype, and the spread of this mutation in Russia is about 30%. It means that there is a big share of patients with this subtype of hepatitis C. They are prone to high risk of developing primary hepatic cancer. And we found out that some of the widely spread in Russian population molecules of HL1, for example A02 or B07, they can link the core proteins of 1B hepatitis if they contain the variants R70 and L91, but not the replacements 70Q. And introduction of screening to analyze those important factors, it's important, and detection of mutation may be important for the next steps in treatment. At this stage of analysis of mutations related to drug resistance and 1B and 3A patients, the important mutations in these patients amount to 5.4%, which is not more than in other countries of the world, though there were high incidence of mutations M28V, about 60%, but among the genetic isolates of type A, and with lots of types of resistances to different drugs of direct action. So this is just only small information. We are very thankful to the organizers for the invitation. I hope that we are going to further advance in that. I would like to thank all of the authors, Dr. Paragyan, Dr. Semenenko, Dr. Malinikova, and other employees. I would like to thank employees from the regions of the country who participated in this work, and I would like to thank you for your attention. Thank you so much. Thank you for listening. Thank you for exciting presentation. The next presentation will be online. Mikhail, I'm very happy to see you and listen to your wonderful presentation, and about the hepatitis C. I would like just to learn your experience. The idea to use chemotherapy in our country to create the special program, it's just this idea is in the air. And also we have a recent article, and authors from Novosibirsk, they just suggest to do that. What about chemotherapy for HIV and hepatitis? So yes. Yes, this idea appeared some 4 years ago. It's in WHO, and there was the European plan established and designed, so where there were lots of different suggestions together with the Commission Yushikov. We published a suggestion to do that for all of the hepatitis. But now we have wonderful opportunities. I know that these works are ongoing. Dr. Chuvanov will speak about that. I think we must do that. We are obliged to do that if we want our future generations to be healthy. We need to do that together with the chemotherapy, and we may use the medicines approved in our country, and there is a big room for discussion the use of generics, and they are flooding our country, and how they are helping people. The question that you ask, it's of high importance, and no doubt we would like to do that. On the other hand, I am concerned that the coronavirus pandemic is an impediment, and there are global examples, successful examples in Georgia on its treatment. But we should now focus and do the studies, all of ours together, to be successful. This is my short answer to your question. May I just announce the next presentation? That's a great pleasure for me to do so. Why? Because it is presented by my friends. So these are the researchers. This is Timur Haililuin. This is a person well known in the world. I am very happy to see you in the screen. Well, that's sad. We cannot. Irkin Isakovich, please. And you have the floor. Can you hear me? Professor Musabayev, so thank you for such a warm welcome. I am not to blame for that. Moscow, Istanbul, so the flights were cancelled starting from April 15, and the whole of our delegation could not come, and that would be a great pleasure to meet in person and talk. This is a bit of too ambitious of a name, so the contradiction paradigm of diagnostic treatment of chronic hepatitis B, what was done by Thomas Kuhn, the paradigms, as he wrote, I mean all of the scientific achievements which give the models and criteria. So this term is widely used, and we have some examples which includes the lore and the theory and the equipment that gives us the models which give rise to traditions of scientific trials. As for viral hepatitis B, the main paradigm those wonderful studies performed by Taiwan researchers 15 years ago. You understand that in the 90s, the quantitative assessment for hepatitis B appeared in the 90s, and with their persistence, they tested and studied over 3,000 patients for many years, and this is the well-known study. In line with that paradigm, everything is related to the viral load. If the viral load is high, as you may see, almost 14%, 15%, in 16 years. Irkin, so sorry, you just do not have the presentation, it's not changing. I'm terribly sorry. We can see you, but we cannot see the slides. Maybe somebody could help. Yes, we have here the IT guide now. Can you know? When we had the Olympic Games, so there was Rodney Nine Zaitsev and the music stopped, and without music, they received the golden medals in the Olympic Games. I'm sure that you can do that without the slides perfectly. Sorry for such a technical delay. Well, it's not working. What can we do? So you may start your presentation. So I explained the first slide, the next one. Yes, we can see it. We can see it. I'm sorry. I already explained those studies from Taiwan, according to which it all depends on the viral load. This is the paradigm which remained unchanged for 16 years. And the same is applicable for cirrhosis risks, high the viral load in each third patient. In 16, 18, 15 years, the cirrhosis is developing. And also there was a paradigm which shaped the treatment of chronic hepatitis B. If we look at the mutation, so these are the stages of replication, viral replication. Only hepatitis C, as there is no nuclear introduction, we can eliminate. For HIV, we need to work on the replication, suppress it, and 4B as the high load has an impact, and the low viral load had no impact. All of the national, international, American guidelines and studies, they were about that. And we are not discovering anything new. When we developed the national protocol in Uzbekistan, when we have to use antivirals and when not, there were 2,000 copies of international units. And of course, if there are some factors related to family history or cirrhosis, these 2,000 copies should be looked at and the ART would be prescribed. But in fact, as you mentioned, Mikhail, in your excellent presentation, before my presentation, that the problems when hepatitis B is the following. The available drugs did not solve those problems because they have no impact on the DNAs inside the core, inside the nucleus. They impact on the pregenomic RNA replication, and in line with the paradigm which the as research from Taiwan came up to, that was not bad. Let us decrease the load to get to some low levels, so everything will be fine. But all entecavir, ribavirin, they have no impact on the circular covalent closed DNAs, and this is the joint work with the Institute of Pasteur from St. Petersburg. We had 75 biopsies with end stage of liver diseases, and we checked the level of the RNA DNAs in rat. Unclear theology. There is no DNA, there is no HBS, and half of those who have pre-cirrhosis or cirrhosis, in half of the cases, we would find the equivalent closed DNAs. So the etiology was found only in biopsies. We found these things. And the first contradiction against the paradigm, not everything can be solved with the viral load. If there is no viral load, if this is hidden hepatitis, it can lead to severe complications and end stage liver disease. The second paradigm, and the second contradiction that all of the protocols ignore. In line with all of the protocols, I would like to just mention national, European, American. Every 3 months we need to check the viral load, but nobody identify how frequently it is changing and how frequently inactive hepatitis gets to inactive and vice versa. And there is no clear data how the viral load is changing for hepatitis B. There is data on a reactivation of the process after immunosuppressive chemotherapy with autoimmune disease. In absence of those factors, it is believed that these things happen in 20 or 30% of the cases. And also, there are guidelines to do that every 2 or 3 months. But here there is economic details, and the ideologists analog, who is speaking practically at all Asian and European conferences. Well, I heard questions at 2 congresses. Do we have to test the viral load every 2 or 3 months because the price is less than one test, and the tenofovir has very minor side effects. The data on adverse effects of tenofovir you see for TTF, right? And especially after 6 months, so they're not different. And after 50 or 60 years of age, and they are taking statins, and the results from them may be much worse, though the statins are taken without any limitations. So the next contradiction in the paradigm: if we are treating those with high viral load, can it have an impact on epidemiological aspects? Will we be able to decrease the incidence in those who are not vaccinated? And what are the learnings from AIDS, working with the AIDS? Hepatitis B compared to HIV, it's much more contagious, a small dosage from an active phase sick person, so the viral load is going up, and also the high viral load is related to a horizontal and vertical transmission. So it means that we could not impact the incidence with our treatment scheme. What happened with HIV? Only when in Africa they started to treat everybody irrespective of viral load, incidence started to decrease. Before there was an idea to treat everybody, not to look at the viral load, there was no major impact on the incidence. In fact, if we are treating everyone irrespective of independent of the viral load, like with HIV and AIDS, it will have a good impact on the incidence of the disease. The next aspect: treat all of the patients with a chronic HBV. There is a social, economic, and also scientific basis of that. So to do 15 years studies like in Taiwan, and of course this is difficult. Maybe somebody will start such studies, but there are studies which speak indirectly about the following fact. So early use of antiretrovirus may have impact on the incidence of complications. So these are the studies from Hong Kong. So this is the infected people. So HIV infection, the risk of hepatocellular carcinoma, and patients with hepatitis B. And you see what's interesting here. And in the group of mono-infection, these numbers were 5 times higher. And the researchers conclude that HIV and hepatitis have a low risk for hepatocarcinoma compared to people with mono-infection. In the group with combined infection, so the incidence was lower. Maybe the severity was low because anti-retroviral treatment for hepatitis B. So this treatment was started early and without assessment of the viral load. Tenofovir, other drugs, lemomedine is used. These medications, so they also have an impact on hepatitis B, though they are used for HIV. So the American researchers, there was a big cohort of patients with the co-infections, double infections. So they looked at randomization, all of the comorbidities. So this is the first table, and how many cases for monoinfection and how many cases for co-infections. So the 5 times less for co-infection. This is a paradox compared to monoinfection. So once again, we can make the same conclusion. HBV infected patients in the US, the frequency of hepatocarcinoma was for patients with HIV compared to monoinfections, and also the co-infection was associated with a decrease of long-term risk of hepatocarcinoma compared to monoinfection patients. It is proved by cohort studies, and we make the same conclusion. If HIV provides the early access to treatment, universal treatment for patients with infection can decrease the risk of hepatocellular carcinoma. And so this is the work of French researcher. This is economic analysis, which was offered by ESOL in 2020. So they analyzed cost efficacy of treatment with nucleosides. Now the price is $15 or even less. And treatment of all of the patients after diagnostics of hepatitis B is the most coefficient, and they were calculating the complications even for the low viral load, and they looked what would be the result, final result, like aspirin for people with the cardiac disease, ARTs. Now they just become like anticoagulants and statins. It is believed that we should treat everybody with that. And there is conclusion that early treatment provides for less consequences and side effects, hepatocellular carcinoma and liver disease cirrhosis. So we should use more treatment at the early stages. And my colleagues will explain what we did in the pilot. So this is the extract from the pilot trial approved by our ethical committee, and 250,000 citizens of Tashkent were tested, and so you may get to active phase, and you may have cirrhosis and other complications. And in line with the national protocol, so the treatment is given for active phase patients, and we give it to antigen positive patients. Tenofovir, we use it for all of patients of HBs antigen. Well, that is probably it with me. The only thing about the change of paradigm. So this is scientific revolution, and we are not going to do any revolution, but That is the idea which is in the air, and gradually we get more and more supporters to change the protocols, the national and the international one, to treat all of the patients with chronic hepatitis B, irrespective of the viral load. And to conclude, I would like to thank the SDA Foundation, which allocated the budget, and despite the severe pandemic times in 2020, we had a big study, and we published it. I'd like to thank my Russian friends, the doctor of medicine, Mr. Simonov. He became the director of the Yekaterinburg Institute of Viral Infections. If he is listening to me, I would like to congratulate him and my assistants and my helpers who were involved in the studies of DNA. Thank you for your attention. If you have any question, I think we have a second presentation.
Только большая просьба сделать его компактнее, потому что последний...
Just please be brief, just 10 minutes.
Потому что как бы общий блок он не займет больше времени, чем мы просили.
Здравствуйте, уважаемые коллеги.
Dear colleagues, good afternoon. For us, that's a great honor to speak about our pilot project on elimination of viral hepatitis in Uzbekistan, organized by CDA, US Foundation, Scientific Research Center of Virology and Healthcare Ministry of Uzbekistan. The goal of this pilot was to demonstrate the efficacy of simplified recommendation on screening and treatment of chronic viral hepatitis, so that our country could launch that at the national level and to get to WHO goal to eliminate hepatitis by 2030. Here we may see the map of this project, and it's split into several stages. So the first stage, it's the invitation for a test, was screening, then registration. Registration was online in the local clinics, and the patients would come to the reception. They would fill in the personal data. After registration, they would move to the next room for express test, and it would take 20 minutes. And also the positive patients, they were transferred to the procedure room for the next test. And we did express test for HCV, for HIV, HBS, and after that positive were referred for consultation. Patients for positive hepatitis C, we would sample blood for further confirmation of the diagnosis in the central lab. This is in the Scientific Institute of Virology. And also test AST, thrombocytes, and creatinine level. Test results took 2 or 3 days, and then the patients would come back to see the doctor to get the consultation. Hepatitis B and C and blood sampling was done in the local clinics in Tashkent, and a total of 13 clinics participated in the program. 2 or 3 clinics worked at the same time. and every month there were 3 or 4 new clinics which joined all of the patients with positive HBC, HG, or anti-HCV. So they had a consultation with the nurse, which was previously trained. And in the first 3 months, the patients of UHAP were sent to Virusology Scientific Institute, and also only patients with complications were sent to hepatologists, and then the doctor is informed about the cost of ARTs and was accessible, sent them to pharmacies. A vulnerable group of patients received it for free in the Scientific Institute of Virusology. Data collection. It was obligatory to get a signed consent form, the contact information, patient records, and the records of the doctors were entered into one single medical register REDCap. All of the clinics and medical employees, so they had the laptops, mobile routers, and tablets, and the system of a unified electronic register prevents secondary testing and provides for the mechanism of follow-up. For UHAP in Tashkent, we used the express test, antiretrovirals, and electronic equipment. I am not going to just read them.
Ключевая статья.
Here you see the key statistics for the projects, and it's the following. The UHIP project started on December 6, 2019. Within 7 months, 62,000 people were screened for hepatitis B and C. 1,810 people were screened per week. We have identified almost 2,700 people with positive for hepatitis B and 2,200 people with positive hepatitis C. This project was running between October and March. Then there was a gap due to the start of pandemic, and then in December last year it was resumed. If you look at the general incidence, it is equal to 4% for HBs antigen and 3.5% for anti-HCV. These graphs show you that hepatitis B is more prevalent among men compared to women. And same was true for hepatitis C as well. As for primarily diagnosed hepatitis B, it was prevalent in the group between 20 to 50 years, and again was more prevalent for men. And as for hepatitis C, it also prevailed in the age group of between 20 to 50 years and was more prevalent among women compared to men. If you look at the treatment cascade for patients with hepatitis B and C, as you can see here, those who were registered, they were underwent express test, but then only 86% of tests would take another blood draw. And as for patient consultation, it was given only to 57% of patients, and then only 71% from that category bought an antivirus medicine. If you look at hepatitis B cascade, out of all identified cases, 88% went through the repeat test, and 70% of them received consultation, and 86% from that category received prescription. In 2021, we launched the national screening program for chronic hepatitis in 7 regions of Uzbekistan. This year, we are planning to test 500,000 people for hepatitis B and C. At the moment, we are preparing to launch the program. And by using this opportunity, I would like to thank CDF Foundation for the support, as well as the entire medical personnel that was engaged in developing this program. Thank you very much, and I will be happy to answer all the questions. Thank you so very much for this great report. You know, I was listening to you, and I was thinking is that we have a common problem, and it is so important your endeavor, what you do, and we need to plan an event where we could exchange experience when it comes to our efforts aimed at eradicating this disease. In autumn, we are planning to hold our traditional conference dedicated to hepatitis. So far, we don't know whether this will be face-to-face or online conference, but anyway, we need to dedicate a session to dedicated to this issue. Absolutely, and I count on you arriving to Moscow. So I will get in touch with you at the end of this session. And now I give the floor to my co-chair, Elena Valerievna. Yes, I understand that the next report will be given by Mikhail Chulanov, who is the chief specialist on infectious diseases at the Ministry of Russian Federation. So he will talk about eradication of hepatitis infection, prospects, and ideas. Well, the floor is yours. Hello, Mikhail Mikhailovich, Elena Valerievna, thank you very much. We continue discussing virus hepatitis subject, and I would like to talk about prospects for eliminating hepatitis C in the Russian Federation. And I will start with the overall review and what we observe when it comes to incidence of hepatitis C. So here you see the data from the last global report for viral hepatitis, and this is the report developed in 2017, and you can see the hotbeds worldwide where the incidence is the highest. And of course, the European region is second largest in terms of the incidence of hepatitis C. So we can see 62 cases per 100,000 people are registered in our region. Indeed, that's a very high indicator. And the Russian Federation, as the largest country in the European WHO region, is ranked 6. And here we can say that the largest countries make up 80% of all patients with hepatitis C. And in Russia, we may have up to 5 million patients that may have chronic hepatitis C. And talking about elimination programs, we rely on the global strategy of healthcare segment and their efforts aimed at counteracting the disease. And we remember that the initiative was approved in 2016. And here you see the key indicators of the global strategy, and of course the most important for us are the incidence rate and the mortality rate. So the goal is to increase the incidence by 60% and the mortality by 65%. Decrease the incidence by 90%. So it is very important for us to provide sufficient coverage with medical treatment, and this is another indicator. So we believe that 80% of patients should receive treatment by 2030. So let us talk a little bit about the relevance of this problem for the Russian Federation, and contrary to usual logic, I would like to start with data on mortality data and on the outcomes related to development of hepatitis C. If you look at this slide, by the way, again, you see the data for 2015. You will see that as of 2015, there were 35,000 lethal outcomes from fibrosis and cirrhosis of liver. Knowing the etiological structure of cirrhosis and knowing the contribution of this or the other virus in the disease development, and we knew that hepatitis C was the most contributing factor, we can do simple calculation and know that in 2015, around 15,000 people died from chronic cirrhosis caused by hepatitis C. So look at the upper graph and the curve that shows the increase in the incidence of liver cirrhosis and fibrosis, and this year we can certainly expect higher statistics because 5 years have passed in that time. If you look at the mortality rate from hepatocellular carcinoma, here we can say that around 10,000 people died from malignant tumors, and 50% account for hepatocellular carcinoma. And we also know that it is easier to do the further calculation, and we know that in 30% of cases we register hepatitis C, and if you add 50,000 to 1,500, we can say that 16,500 people in Russia die from hepatitis C. Statistics for hepatitis B somewhat better, but again, total it will be around 30 to 35,000 cases, lethal cases, what indeed is a large burden for the Russian Federation. And the next slide demonstrates you the etiological structure of chronic viral hepatitis. So what has a larger weight? The red column stands for chronic hepatitis C, and since 1999 to 2090, we see gradual increase of the share of hepatitis C when it comes to etiological structure. And talking about the incidence and the number of new cases of chronic hepatitis C that were identified in the Russian Federation, of course, you know the statistics well, and you know that the peak fell on 2014. Then we were able to stabilize the situation and even decrease the incidence. But look at the last two bars standing for 2019 and 2021. So in 2019, we had 30 cases per 100,000 people, and in 2020, we had 17 cases per 100,000, and that is a total of 24,514. So, this jump from 31 to 17 has nothing to do with frequency of registering new cases. This is basically is the contribution of coronavirus infection that cause the problems in terms of registering the patients with chronic hepatitis. And if you look at the follow-up hospitalizations, we see the curve goes up steadily. And here we see that the figure increases from year to year. And here, so far, we cannot stabilize the situation. So here you see the mosaics of incidents in the Russian Federation. Marked in green regions are the ones where the incidence is lower, and then the brown and pink ones are the ones where incidence is higher than across Russia. But we know that the real figure depends not only on the true incidence, but also on the way the registration is organized, and a lot of regions still have to improve the situation in this regard. It is always important to understand the age structure of the incidence, and here you see the frequency of registering data on patients in different regions. And I will never get tired of saying that we should do our best to stop the peak, and we can see a better situation in the age group 20 to 30, and also for the age group 40 to 50. And we understand that with age, the chronic hepatitis C progresses much quicker, especially after the age of 40. Therefore, we can expect a large share of cirrhosis and pronounced fibrosis among patients older than 40 years of age. And we know that if the entire population has a 25% share with a pronounced fibrosis, but if you do the age-related breakdown, you will see that the share of patients with cirrhosis in the older population is much larger, and that is certainly very worrisome statistics. And again, it is something what we have to solve. As for incidents, we already have talked about it. I always provide figures from Central Institute of Epidemiology, and that is the agency that tracks antibodies to hepatitis C, and the figure has always been around 4. Of course, this is an average figure. Some populations may have lower level, others higher. And if you look at age group between 30 to 50, the figure will be higher than 4, especially among men. There, the indicator can be almost as high as 8. We are talking about the frequency of identifying antibodies for HCV, and we understand what age and gender groups we should focus on. Talking about the incidence of genotypes, that is something what we already have talked a lot about, and over the past decade, the situation has not changed dramatically. So we can see that the dominating genotype is B, and then the second most popular is genotype 3. Its share varies between 35 to 45% in different regions. Of course, it's very important to understand the distribution of genotypes for hepatitis C. And now we have pangenotype medicines that provide stable response regardless of genotype. Therefore, the identifying genotype from clinical standpoint becomes less and less relevant. Here you see the distribution of genotypes. Maybe third genotype share has increased a little bit, and the share of the first one went down, but it's not statistically significant. And here you see the distribution of genotypes among the age groups, and logically for the young population the share of third genotype is high, and we knew that very well. But again, it's important to take it into consideration, especially as we plan our treatment program. So we need to understand which groups need pangenotype medicines. As for the cascade of providing treatment for hepatitis C patients worldwide, again, this is the data from Global Report from 2018. Well, I demonstrate this slide just to highlight the fact that the coverage of treatment is a large problem for the entire globe, not only for our country, but the success of certain countries is very important. And again, success rate can significantly differ. So we know that 70% of those who have to be identified are not identified yet, but out of those who were diagnosed, 70% still did not receive the proper treatment. Well, here you see the map that demonstrates the worldwide situation, and it shows how close certain countries are to reaching the goals of WHO when it comes to eliminating hepatitis C. Marked in red are those countries that are still far, far away, and unfortunately the Russian Federation is among the countries in the red segment, but there are countries that have invested significantly in the elimination programs, and you see marked in red are marked in green are Australia, Egypt, and other countries that have made a huge breakthrough over the past years and were able to decrease the incidence significantly, and also provided efficient antiviral treatment. Well, we do have these tools, and Here, the following slide shows you what the countries in green sector do. So Australia does not limit the access to hepatitis C treatment. France also provides access to treatment for hepatitis C within the framework of the national system of medical assurance. Georgia has done a great deal to eliminate hepatitis C and carried out very efficient screening and treatment programs. And of course, Portugal is on the way to eliminate the disease. Egypt has also enjoyed huge progress and implements efficient programs.
Лечение, тем самым значительно снижая распространенность заболевания в стране.
Cases is going down in the country because of the efficient programs.
Безинтерфероновая терапия, красная.
And so this is non-interferon therapy, IFN-free and IFN-based, so it became more available and accessible over the past years. So this is our cascade of treatment for today. Different types of assessments, and for if we will focus on 4% full antibody, it's 5.7 million. And incidence, half of them. And most of the patients are beyond the constant monitoring. Only around 700,000 are on under constant supervision and follow-up, and the average of 18,000 people per year in the country are getting the treatment. This number is not enough to change the situation in Russia. Several examples from the regions in Primorsky region. It's about 500 people every year, and at that time, in the data is for 2018, mostly there was interferons used. Only 30% were getting the direct ARTs, and of course the number of people treated is not enough. And also we look at Yakutia region at the incidence and the prevalence, and blue average in Russia, red Sakha Republic, less than 50 per 100,000 of population, so it was never less than that. So the new cases. And the number of cases in 2017, so it's 501. And every year we add 500, and only 1,000 treated in 6 years, so that's not enough. So the data from Chelyabinsk region, where the regional program has in place for a long time, and despite the presence of this program, which is good, look at this year. Every year we have 2,000 new cases, and we are treating 140 people per year. That's not enough. This is according to Sagalova Olga. Some words about how we treat chronic hepatitis C in children, and we did that study with Mr. Labzin, and into 2020, as of September 2020, 268 medical institutions from 37 regions of Russia were questioned about the treatment, and 8.8% of children were treated, and most did not receive antiviral treatment. If we look at the age groups, so mainly from 6 to 17, so older age groups, and if we look at the medicines used in 50% of the cases, IFNs were used, though today in Russia we have accessible schemes of ARTs for children older than 12. We could use ARTs for them. How COVID impacts on viral hepatitis C. So it has no impact on the progression of COVID, and it was demonstrated in several studies, and how the pandemic is influencing the elimination program. This is a different story. There can be negative and positive impact, and more negative, of course. So decrease of access to diagnostics and medical care provision. The regions, they have some financial limitations because of negative consequences of the pandemic. Nothing has changed in terms of safety of blood and the risk of vertical transmission, but still there can be some positive impact, which is development of lab services, increased accessibility of medicines, and improved delivery to 5 areas. Vladimir, sorry, just time. Yes, I'm just finishing. I will skip this slide then. I'm not going to give the details about what we have to do. We understand that. And what is important is the development of a long-term program for treatment of hepatitis. And in green, this is the profile, and in red, so these are the goals of WHO, and the green is our goals. What is the way to go? I'm confident that we will use the red curve, and Vladimir Putin half a year in his message to our senators raised the question of hepatitis C and its importance, and he said the goal to minimize incidence of hepatitis C in 10 years by 2030. For me, it is evident that we will go along the red curve. Thank you for your attention. Thank you very much. Unfortunately, we have no time for questions left. If we have some time in the end, so we will do that. Thank you so much, and that's a great pleasure to announce the presentation by Nuria. We have timing. Dear colleagues, I'm very happy to speak from this floor. I'll try to briefly speak about our experience of people living with the HIV, and my presentation I could not open it, could not open it, and I will just speak. So the main documents that we use for this program, treatment of chronic hepatitis C in PLH PLWH. So this is the state program of Kyrgyzstan to fight against HIV for 2017 and until 2022. The clinical protocols, the law on treatment of HIV, and as of beginning of our programs, so there was the healthcare ministry order in place, the clinical protocols for HIV dated 2017. At present, it's not valid, and the new clinical guidelines are in place. Treatment of HIV and comorbidities in Kyrgyzstan Republic, and based on the decree of healthcare ministry about the ART direct drugs for people living with HIV/AIDS. There was patient selection performed to take on patients with HIV to treatment of hepatitis C. We had two goals. The first, to improve the quality of medical care, to decrease the burden of viral hepatitis in Kyrgyzstan, which is a threat to public health. It means that 90% of HIV positive will be tested for hepatitis C. 100 patients per year will be treated against hepatitis C. And the main goal, the second goal, which is elimination of hepatitis C by 2030, in line with the global strategy of WHO. And we use the electronic follow-up. So this is the electronic database. Statistics, analytical records, and medical records. So as it was mentioned earlier, virus hepatitis C screening in PLWHO is not enough. What we do, starting from the year 2016, there is a trend towards increased number of screens among PLWH, and there is increased incidence in our patients of hepatitis C. I will give more details and the selection criteria for PLWH. So we used them for this program in line with the order of a healthcare ministry to pay for the patient to be included in the program. The commission made the decision to include the patient for treatment of hepatitis C, and the commission included doctors from AIDS services, non-governmental services, and also the informed consent was filled in. The age 18 plus, and the treatment was supposed to include patients with the viral load and with the maximum number of scores. So there were scores assigned, and comorbidities, severe comorbidities, were a limitation to start treatment, and the treatment would be started only after the condition was stabilized, and the treatment is also necessary for high risks of medical interactions should be postponed. I mean, the ART combination efavirenz, lopinavir, itanavir, so they can interact with anti-direct ARTs for in treatment of chronic hepatitis C. The next patient selection criteria was the following. So ALT enzymes, fibrotic enzymes, fibrotic tests, ultrasound of liver, elastography. Co-infection of virus hepatitis B and C in PLWH and medical workers, childbearing age women, key groups of population, and it was necessary to prepare the patient. The patient was supposed to take such tests as CD4, thrombocyte count, platelet count, blood assay, non-hepatic signs of virus hepatitis C, such as arthropathy, vasculitis, and symptoms of cryoglobulinemia. Or also one of the patient selection criteria as well. To cut the incidence among the medical workers, we would prefer that as well. The patient was supposed to be follow-up, compliance should be high, and the patient was supposed to get antiretroviral therapy, and ART compliance should be high. And in order to make monitoring of efficacy of treatment for the patients, needed to take blood tests for PCR, and he need to come to visit the doctor for that purpose. And the monitoring of efficacy of ART therapy is standard 4 weeks, 12 weeks, 24 weeks, 36, 48, depending on liver cirrhosis. And also there was a need for control of the usage of treatment, so they check the passport and the limitation of the pills amount. So usually they are given away for 4 weeks, and then they would change the package for a new one, and the accessibility of veins for blood tests. Monitoring efficacy of treatment of viral hepatitis C was done with the treatment of during the treatment and after the treatment of hepatitis C with antiretrovirals with the direct ARTs. I will briefly explain the financing, and all of this program is financed by the state. If we look at the treatment schemes for one patient, there are 2 schemes which were used. Daclatosphere as flavovir, so it would be less than $900. For the second scheme, sofosbuvir vilcatosphere, so it costs 2 times less, for $150. If we look at the costs of treating 501 patients with PLWH in our country with the hepatitis B. Less than $160,000 were spent on that, and per patient, per treatment course, 12 weeks length, the price was around $300. The efficacy of treatment was assessed in line with the database. It was around 80% from the patients who could take the diagnostics with PCR. Not all of the patients took the tests. And also the coronavirus may be one of the reasons for that. And my conclusions, the risks during provision of services to HIV positive or with the hepatitis C under state financing includes no fibroelastography. Fortunately, the patients had elastography rarely using their own funds, and some cases when they didn't want to do monitoring of efficacy of treatment. And I think that COVID-19 had the impact here. From all of the rejections, 75% of rejections were from key groups such as, key groups, and also the doctors would introduce the data later on in the PLH group, and we don't have enough specialists for patients with severe cases, for comorbidities, and with severe comorbidities. There was a hepatitis C patient with leukemia. Unfortunately, we could not help because of absence of hepatologists, top level ones. And during COVID-19, so we have also failures in our diagnostics because the lab service was fully utilized for the diagnostics of coronavirus infections. How to solve this problem? Fortunately, we don't have the state program to fight against the burden of viral hepatitis. We need to advocate the state program to do the tests under state program to assess the incidence of viral hepatitis in Kyrgyzstan. We need to expand the financing for more activities, and the results depend on that. And we all know that hepatitis treatment is prophylaxis of cirrhosis and liver cancer. We need to perform monitoring. This is recommendation WHO, and we need to train our specialists on management of patients with hepatitis. That is it with me. Thank you for your attention.
Спасибо большое. Вы знаете, у нас
Thank you very much. We had certain changes in the program. Yelena, maybe I'll just announce, because as far as I understood, Timur Khairulin, he will not speak. So this is the co-author of my presentation. I will make the presentation, if you allow me.
просьба.
but I kindly ask you to be quick, and we still have another presentation to go, and we have run out of time. I'll be short. Can you see my presentation? Yes, we can. So, dear colleagues, allow me to give you a short review dedicated to relevant issues of treating co-infections of HIV and hepatitis C. So let's start with the available guidelines that exist worldwide. So here you see the guidelines from the 3 leading associations, that is the EASL. The guidelines were updated in September 2020. Then the guidelines of ASASLD that renewed their recommendations in August 2020, and the guidelines of WHO that renewed their recommendations in summer 2018. And let us focus on those guidelines that are that have seen the most recent updates. So let us look at the screening group for hepatitis C. Our American colleagues believe that the routine one-time testing for hepatitis C is recommended for all patients older than 18 years of age. Patients younger than 18 years of age should be tested for hepatitis C once time. In case of risk factors availability, prenatal testing should be done at every pregnancy. Annual testing is recommended to all consumers of injection drugs, male that practice sex with a male, those that practice non-protected sex encounters, and also to men practicing sex with a man who use pre-contact prophylaxis. Per our European colleagues' believes, screening for hepatitis C infection should be offered to all people that were tested for antibodies and were diagnosed with RNA of hepatitis C. Who and when should we treat? The goal is to decrease the overall mortality and increase the morbidity rate for liver diseases by achieving virological treatment. And our American colleagues believe that treatment should be recommended to all people with chronic or acute hepatitis C, except for patients that have short life expectancy, and it cannot be increased with transplantation of liver or other methods of treatment. European colleagues believe that treatment should be offered to everyone who have not received therapy previously and who has chronic or recently received infection. And the treatment should be started as early as possible. Acute therapy should be offered to patients with fibrosis of F2, F4, decompensated cirrhosis, clinically relevant extra liver symptoms. And the treatment is not recommended for patients with short life expectancy. Talking about genotype assessment, pan-genotype regimen therapy, including GLP and PIP, can be started without identifying genotype and subtype that will make lab diagnostics cheaper for such patients. It is also recommended to test patients for genotypes and subtypes that live in the regions where there is a high incidence of those genotypes that are hard to treat or that demonstrate certain resistance to treatment. Per American Association, genotype detection takes place in case it may impact the choice of the treatment course, and that, in other words, is an option when it comes to identifying the treatment. Cirrhosis has to be identified or eliminated, and so it is recommended to offer additional diagnosis. Examination prior to treatment should be given to all patients with hepatitis C, and it is recommended to evaluate non-invasive markers or carry out elastography, and in certain cases the biopsy of liver should take place. Testing for mutations should not be recommended to primary patients, and in the regions where the drugs that require mutation tests are used, testing should be done. Mutation testing should be done for 3 combinations: elbasvir in combination with grazapvir, ledibasvir with sabopfovir, and sabopfovir with rodapasvir. Genotype-specific approach per EASL is presented on this slide. So 2 component regimens are recommended, that is glicapavir, pifrinasvir, and sovasbuvir, vilatpasvir, and grazapavir, lasbavir are recommended only for first subtype of hepatitis C and only for 12 weeks of therapy. 8 weeks of therapy is not recommended any longer. Combinations that are recommended by our American colleagues for more prevalent genotypes in the Russian Federation are shown on this table. Talking about peculiarities of using sovetosphere and velatosphere, so the combination of Sovel is offered to suboptimal patients with compensated liver cirrhosis with a mutation of A93H. 8 weeks of therapy with gazaprevir and erbivasvir are recommended for suboptimal primary patients with F4F2. Experts recommend only 12-week course and only for 2B genotype of hepatitis C. Talking about possibilities to simplify the approach to therapy. The simplified therapy of hepatitis C should be used to increase the access to treatment when genotyping is impossible or not acceptable or limits the accept. Prior to treatment, it is sufficient to confirm the presence of hepatitis C infection and identify the presence or absence of cirrhosis. It is also needed to do the assessment of medicinal interaction, and UVO12 evaluation is not mandatory. Talking about simplifying the approach to therapy, it is recommended to offer 8-week therapy with glicapavir, pibrentasvir within 12 weeks and 12-week therapy with sofosbuvir and vilbitasphere. New simplified approach is also recommended by American colleagues. After simplified examination, the patients are prescribed with one of 2 pangenotype scheme, glypacravir, pimprinasphere, or sovasbuvir, vilpatasphere. Monitoring the case of treatment should be simplified as well. Talking about acute or recent hepatitis C, talking about timeline of 6 to 12 months, gligitavir, pibratosphere, or sofovir, vivaltosphere for 8 weeks. stable viral response at week 12, and post-contact prophylaxis is not indicated. As for the conclusions, I will not read them because they are available on the slide. And with this, I would like to finish. Thank you very much for your attention. Thank you very much. We have 2 more reports to go. I'd like to give the floor to Oganes Madayan, who will talk about state program of hepatitis C treatment during COVID-19 pandemic, challenges, achievements, and lessons learned. Thank you very much. I will be really fast, and I will focus about the importance of integrating our measures aimed against hepatitis C and COVID, and which HIV based on the examples of 2 projects. How do I change my slides? So we carry out 2 projects. One is carried out by the National Center for Infectious Diseases that I represent, another one by the National Institute of Healthcare. Over the past 10 years, Armenia has seen the increase in HIV spread. The main transmission way is heterosexual, and the main risk group are heterosexual men that leave the country in search of work, and as for transgenders, their share is less than 20%. I have skipped this slide, and if you do the calculation, you'll see that every 3rd HIV positive person in Armenia does not know about their status. So we are carrying out work in order to reach 90-90-90 goals set forth by UNAIDS. This slide tells you that the largest incidence is observed among labor migrants. So as for the structure of testing for HIV in Armenia, what is the problem? The problem is that we are not able to find those 33% that live with HIV. In our country, we carry out 140,000 tests for HIV, and 0.27% of all tested people would have a positive result. Within the framework of our project, we decided to introduce testing in the outpatient clinics, and we looked at 2 approaches. Based on one, in the city of Yerevan, we decided to improve the attractiveness of HIV test, as well as syphilis and hepatitis C. And in other regions, we provide additional financial fundings to those clinics that encourage the patients to do the HIV testing. So we saw a double increase in the number of identified cases, and that allowed us to increase the efficiency, and also allowed us to identify HIV infections at early stages, because it's well known that when the infection is identified at hospitals, the disease has already progressed significantly. So if you look at lessons learned, I would say that the testing for hepatitis is so attractive for the population that the doctors were able to persuade the population to do tests for HIV as well. And that's something that should be continued, that should continue being done. And if you use the existing infrastructure, the costs are quite efficient. So introducing this model coincided with the project dedicated to treating hepatitis C in Armenia, and I believe that my colleague Marina Konstantinovna will talk about it with more detail. All right? Okay. So we are waiting for Marina Sarkisian, but she is the Deputy Chief for Science and the head of the Department of Epidemiological Diseases at the Institute of Epidemiology at the Ministry of Health. Hello, dear colleagues. I will try to be really fast because I understand that we are lagging behind our schedule and you might be very tired by now. So virus hepatitis are the global threat to public health, and for a long time this problem was not a focus of the society. It's a huge problem in the European region, and we believe that 14 million people suffer from chronic hepatitis form. We know that the 66th session of Regional Committee of WHO, the member states committed to eradicate virus hepatitis till 2030, and that included 5 virus hepatitis, although the focus is on hepatitis B and C as the most relevant forms. And the program is aimed at containing the number of cases, providing accessibility of testing, and providing also affordable treatment for all patients. The new era in treating chronic viral hepatitis C is marked with high efficiency of direct medicines of direct actions. It shows good tolerability and decrease in the duration of treatment. The first genotype of the disease in Armenia is observed in 92% of cases, and the frequency of viral response would be really high. In November 2018, the Republic of Armenia, with the engagement of the Center for Disease Analysis Foundation, CDA Foundation, in cooperation with the European region of WHO, local office of WHO in Armenia, carried out analysis of main results of hepatitis C and B burden. The results were included in the report about the impact of the disease on the public health of the Republic. So taking into the account the published study results, expert consensus was reached, and it was calculated that around 4% of adult education of Armenia, that is around 88,000 people, have seropositivity for viral hepatitis C. And considering the fact that viremia is observed in 70% of cases, that means that 68,000 people in Armenia have chronic hepatitis C, what is equal to 2.8%. According to data of as of 2018, the number of cases of viremia reached the peak in 2008, and it will go downward. And by 2030, we should have around 46,000 of cases. It was mathematical simulation, and we did the calibration with the use of epidemiological data, and it was calculated that if the situation maintains the same and no measures will be introduced, by 2030 the number of deaths related to liver lesions will increase by 8%. So, and we also will increase the number of new cases by 6% and decompensated cirrhosis by 8%. So here you see the curves of mathematical simulation calculation done by CDF Foundation, and here you see curves in 3 colors. So the dark curve stands for a situation if nothing would be done, and in red we see what we will have if we use the stepwise model, and green if we use the WHO. So talking about stepwise scenario, it is aimed at gradual improvement in diagnostics and treatment in line with capabilities of the healthcare system. So we should have a maximum of 3,000 patients by 2026 and subsequent period. If we adopt the WHO scenario, by 2030, we will have to have a large number of diagnostic cases, and we should have around 5,700 people undergoing treatment by 2026. So here you see what will happen if we choose stepwise scenario and what we will have if we opt for a WHO scenario. So far our country is more inclined to follow stepwise scenarios. So we were supposed to start in 2009, 65%, and that should save 660 lives. If we use the WHO scenario, then we will see that the percent of decrease of decompensated cirrhosis and the number of listed lives will be greater. All scenarios are economically effective, but the second one certainly is more efficient. Here you see the results of mathematical simulation. So if we use the WHO scenario, you see that it requires high spendings, although we see that at a later stage, economically, it's more beneficial. So taking into account the analysis results, in 2019, we received the model and results in 2019. We have developed the state program for treating hepatitis C. It was supposed to start in 2020 at the first stage. It was supposed to cover 1,000 patients, and we are talking about combinations of fosbuvir plus daglatasvir. So previous years, the collection of data would be based on emergent responses, so we didn't have exact statistics, and because we did not know an exact number of patients in Armenia, and we could only suggest how many we have based on mathematical modeling, we chose the model, and patients of first priority were patients with fibrosis of fourth or third level or extra liver symptoms and patients with comorbidities that could have an impact on the course of the disease. So we have developed the standards for the initial evaluation of patients. So all patients are evaluated based on the single standard. We use inclusion and exclusion criteria, standards for monitoring the therapy. We also have developed a checklist for patients and created a group to control the compliance with inclusion and exclusion criteria. We also have created new standard Excel forms to collect more detailed data about patients with chronic hepatitis C, starting from data collection up to monthly distribution of medicines. Here you see the initial indicators that are required to include the patients into the program, because so far we offer this aforementioned combination. Genotyping is a must. We like to highlight that if the patient is not able to pay for elastography, the doctor calculates FIB4, what is still available. So a shipment of subabosphere and glottosphere for 1,000 patients was supposed to take place in March 2020. However, due to COVID, the medicines were stuck in Delhi, and therefore the program started only in September 2020. And this is the data as of April 2021, and you see that 32% of patients are women in the age of 20 to 85 years. 22% have of patients have cirrhosis, and 35% have diabetes. 48 patients have the genotype of 3 and liver fibrosis of stage 4. So there is 24-week therapy. In the near future, we plan to include patients with low fibrosis. So we are planning to extend the program, and patients by 2021 will be included in the therapy. So we will be able to cover as many as 1,500 altogether. So in July 2020, we started program on treating HIV-positive patients with hepatitis C. So we were planning to offer treatment to 200 patients. As of today, 110 already received therapy. 17% have fibrosis of grade 4, and the success for me is the fact that practically all our patients received dolutegravir. So we are planning to switch to triple therapy with dolutegravir, and you see the majority already receive it. So you can see here that 15% are the patients with genotype 3 and the liver fibrosis of 4th stage. So despite the COVID-19 pandemic, we successfully launched the state program for treating chronic viral hepatitis C with the use of antiviral medicines of direct action, the centralized data collection, and the monitoring of medicines distribution is a positive factor. We are planning as of 2020 to carry out the program for training programs for doctors in order to increase their testing. Mathematical modeling with the help of CDA Foundation WHO support allowed us to assess the burden and develop the program for eradicating chronic hepatitis C by 2030. Reorganizing of our infectious service helped us to unite efforts and develop a efficient program for eradicating hepatitis C. Thank you very much for your attention. Thank you. Finally, we finished our program, but unfortunately ran out of time, and looks like we will have no lunch. This is the second day of international conference, and HIV is going down, while today hepatitis C has still high relevance. And in Kyrgyzia, we had 200 cases of transplantation. We have pandemic in Central Asia, and we believe that our situation impacts Russia because we have so many labor migrants coming from all countries to Russia. So let us think about what we can do collectively. I will interrupt you. We will have a huge hepatitis conference in October, November this year. It will go on for several days. We kindly invite you all. Well, this problem is relevant because we could stop the problem with vaccination. You see, we talk so much about COVID vaccine, but we should also offer vaccine against hepatitis C, all right? And think of the migrants. I have been suffering from hepatitis C and D, so it's a chronic form, and I participate in many surveys here in Moscow, but they're not available in my home country. Okay, thank you very much. Why don't you come up to me in the break and we will talk to you, but we really need to wrap up this session. Thank you very much.
Добрый день, уважаемые коллеги.
Good day, dear colleagues. Allow me to welcome you at the session that is dedicated to Epi Surveillance for HIV in EACA region. And our session is dedicated to, again, Epi Surveillance for HIV, and that includes the discussion of questions that have been relevant over the past 3 years. And 3 years ago, we held our last conference. So the reports that we have here to listen are going to be of interest for all of you. And the questions that you may have should be addressed at the very end of the session. So we will allocate some time for Q&A session, but considering the fact that we have a large number of speakers, I suggest that we start, and I suggest that every report should be no longer than 12 minutes. And allow me to present our first speaker, that is Natalia Ladner, Senior Research Associate, Central Research Institute of Epidemiology of Rospotrebnadzor, and she will talk about epidemiology of HIV in countries of EACA.
Dear colleagues, I'm very happy to welcome you. I would like to make a review presentation, and I will just have 2 slides by UNAIDS, and also I would like to speak about other source information. I will speak about the Epidemiological HIV Center, about the WHO, and also I will try to present the data on the country. You may see the key estimates by UNAIDS, so it's different from the data published by the national sources. And according to that data in our region, so mostly these are male, so we have a total number of PLWH 1.7 million 2019. The new cases of HIV 170,000, and this is a new pandemic in this region. Incidence and prevalence coefficient is the highest because it started later on and continues to develop. Another characteristics of the region, according to UNAIDS, so here there are 99% of new cases of infection, and half of them for the key target groups. And the registration data is different according to the National Ministries of Healthcare of CIS in the region of Eastern Europe, Central Asia, and in publications of UNAIDS, some of the Central Europe countries are included with a few cases, and also the Baltic countries usually are not included into UNAIDS statistics, but sometimes they are also included, and I just limited myself to CIS countries and ESDC. So the registered cases, what is the difference from the estimations by UNAIDS? Starting from 2010, by 2020, this is preliminary data. The data for 2 countries, for Kazakhstan and Uzbekistan. And our colleagues will comment on that. So the data as of December was used and extrapolated for annual indicators. We have a considerable decrease in 2020 for the registered cases, and that's not surprising. In pandemic, we have less of tests. And well, just in general, if we are not take into account the current situation, you see that aside from 2015, the number of new cases going down. And if you compare these numbers against 2020 and 2010, so in 2010 these numbers are similar to what we had in 2010. And if we looked at prevalence and incidence for 100 population, and 2 problematic countries is Russia, the green line, and Ukraine, and green, the red line. And the peak of indicators was, you see, Belarus is the light blue. Also in 2015-2016 had a high incidence high prevalence. And the highest incidence rates were in Russia, Kazakhstan, and Belarus, and Moldavia, so as well. So coverage with tests and was growing. And if we look at 2019 data, they are quite reliable. So by 60% was the increase in the number of tests per 100,000 of population starting from 2010, and by 13% the coverage decreased in 2020. And we should understand that the quality of this testing in 2020 was different, because the countries could not just massively test the most vulnerable groups of populations, and that was more convenient for elderly people, people who came to medical institutions. Some slides about Russian population. So we have also the foreigners. In most cases, these are CIS citizens, and over the last year, 2.5 million people had tests for HIV among the representatives from these countries. There is a decrease significant in this last year, 1.6 million of deaths, and the number of new cases also decreased, and 1,600 new cases of infection, and less people came to Russia for earning something, for work, and for other reasons. So this is the share of CIS citizens or from neighboring countries. Most were citizens of Uzbekistan, Ukraine, and Tajikistan. So more than half of all of the cases of HIV were for these countries, and Armenia, Azerbaijan, Kyrgyzstan share was growing, and there were quite a big number of cases of HIV infection despite the decrease in the number of tests. And in all of the years, for all, we found almost 39 cases of HIV in foreign citizens. Usually these are from neighboring countries, less from more faraway countries. And here you may see the countries with a significant share of HIV infected people: Uzbekistan, Tajikistan, Armenia. Up to 30% of the total number of registered cases in the country. So they were in Russia. So there is also a cross link here, but this is a resource for identifying new cases. As for Turkmenia, we have several dozens of cases every year. In 2020, over 10 new cases of HIV among citizens of this country were found, and Turkmenistan is not registering any cases officially in its territory. The mean age of these citizens was about 37 years. 1/3 of them were women. Most of them are men, which is well known as well. If we compare against Russian data, we also have a dramatic shift in the age split in Russia, and the gender split is the same, 40% women. And at the same time, in the year 2000 and in 2010, mostly we had it in young people. Now these are mostly people over 30, and 70% of the first cases at the age from 30 till 50. What are the reasons for the infections? According to European WHO and CDC, well, mention heterosexual as the main way of transmission. It is in line with the data published by the country, but the situation may be very different in countries. And in the next presentation, my colleague who will speak about the situation in her country. And we read the publication that also there are outbreaks among the drug users, and that's not so rare. It is also related to the change of the drugs used in the countries, and there will be a presentation about that. And Russian data is in the slide. In 2016, more than half among the new cases were of a heterosexual context, and in 2020 the share increased to get to 65%, and less now goes for the drug users. The medical care cascade, you saw that it's important that we have lots of achievements, but they are far from the goals of 1990. According to UNAIDS, only 41% among people living with HIV have suppressed viral load, and there is a high mortality from AIDS in our region. And compared to 2020, there is no decrease, but there is an increase, and the mortality among women is growing, and this is a difference compared to other regions. And the last slide I would like to show you, based on my short presentation. Of course, I would like to give more information. So these are the typical pathogens. So the region is uneven, and we have HIV-1 subtype, subtype A6 in most of the countries of the region. This subtype can be found, but in Middle Asia, so the circulated recombinant form HG, and these are isolated pandemics that can develop by themselves. And even in Russia, when we have the citizens of neighboring countries, usually they have sexual contact with people from their region, and they are transmitted with the same type of virus circulating in their region. So this is the joint study about the incidence of HIV resistance and the onset of antiretroviral therapy in most countries. It's 10% prevalence of resistance, but in 2 countries, so it's more than that. The situation is quite complicated, together with a big number of new cases of infection. We also have a complicated general situation. How about the conclusions? Of course, we have lots of successes in our region and tests, lots of advancements in prevention of vertical transmission, and we have still a growing number of new cases, 80k plus of new cases of infection. You remember that when we were adopting the declaration, so we were talking about 40,000 in our region, so we are not even getting closer to those numbers. The age of PLWH, the age is growing in this group, and most get infection in the heterosexual context, but still the growth of incidence among non-traditional sexual context is also growing, and I believe that we could expect a compensatory increase of incidence in the next 2 years, people who were infected. In any case, we will have to find them. What we did not do this year, we'll have to compensate for that. Thank you for your attention. Thank you very much, Natalia. There is nothing to comment, because you covered all of the problems in our region that are really typical for practically all of the countries in the region. Thank you so much. I would like to give floor to our next speaker, Irina Petrenko, Deputy Director of Kazakh Research Institute in Dermatology and Infectious Disease Republic Kazakhstan System of Electronic Case Management of HIV used for HIV surveillance. Hello, dear colleagues, dear participants of the conference, and as our moderator already mentioned, I will provide information about electronic case management used in Kazakhstan. Well, the incidence of HIV has varied difficult factors, so that's why we are looking for IT solutions for that and how to also process and record the data. To get reports, we developed and continue to develop, and we continue to improve different IT systems for that purpose. In this slide, you have the list of info systems that are currently used in Kazakhstan. And I would like to say that during development of this system, it's approval of the phones and the complete compliance of algorithm of work of medical workers to prevent and treat HIV, and also we have the standards for monitoring and the use of ID number to identify the person, which helps to do accounting not only for the number of tests but also for the people. I will not just stop and enumerate that. I would like to speak about these IT systems. First, this is the online registration and the national register of tested population. So this is the system to process data for all of the people tested in Kazakhstan, and it is used in 173 medical institutions. Now it's working in 2 regions. As an ID, the identification number is used. It helps to make the analysis of testing values, and also it helps to work with the data from different organizations. It cuts the time for medical referrals, filing, and also it gives the opportunity to make monitoring of analysis and tests of different groups that we are tracking. It provides for analysis of the number of tested people during different types of codes by diseases and age groups. So in this IT system has a referral, as I've mentioned, and the referral for blood assay, and the diagnosis, and the medical institutions, they create in the register one referral, and so they can be combined if the medical institution doesn't have internet. So these are some just far away locations, or it's in the prison, and the negative results are entered into the register, and the medical institution can give that result. If the result is positive, they confirm this test result, and they enter this information, and this database integrated with the next database. I will speak about that. This is electronic tracking system, so it's automatically integrated into this system. So we can get from this database different information materials with a split by medical institution, age, and so on, so we can clearly track coverage of the population without repetition. And electronic tracking system, which contains all of the epidemiological data, lab and clinical data, and it makes possible to get. Also in this system we can use different variables for reports in different territories, and also you can use different data in PDF and so on. And being a Republican organization, so we can make an analysis of all of the activities and how the epidemiological work, and we can also assess the efficacy of the work of our specialists. I wanted to briefly explain about our system. So there is the medical record with the medical demographical data, ART data, lab tests, and there is a module for ART, and the tools are different lists and registers and so on. Here you may see the screenshot from this program. And you can also make some calculations, and you can visualize the data for CD4, viral growth and trends, and you can also assess the efficacy of ART. And then here we have the module of account and forecasting, antiretrovirals. It's in place in all of the HIV centers, and also we track their consumption, and we can use the scan, and this accounting provides for a control and of the possibility of ART when the ART medicines are given from one region to another. If that is the case, or it provides for automatic calculation of the consumption time based on prescriptions and current level of consumption, and the control of stocks at the warehouse, and other opportunities given by the IT system. So this is for patronage medical nurses to be used at tablets during nursing care at home. At the previous session, there was ICAP representative. He's in charge of that system, and he spoke about its efficacy. We have this system in 3 regions, and it helps medical nurses to improve the medical care. It simplifies it, cuts the time for preparation of different documents, and also I think that this mobile app has very good prospects, and I would like this app to be used in all the regions. The next program I'd like to speak about, it's called EDAN. So this is biobehavioral data, and it is used in all of the centers for a long time, and it provides for rational use of resources and for reliable results on surveillance and on the incidence among key groups of population. Also, the tablets are used, and for a very quick registration of data, and question takes a lot of time. It used to take up to 50-40 minutes, now up to 15 minutes, and excludes mistakes in the questionnaires. And also you can look at personal records online. There is no need to rank the records, and also there is a remote control for that, the quality of assessment, quality of collection, and we can assess the timing required. The next slide, it's the screenshot to prove my words from the database itself. The next information system, which is used successfully. Currently, it's under use, and now there are some amendments that introduced. This database provides for automation of all of the processes between medical institutions, outreach workers, and the customer. Improves control over coverage and helps to track the volumes of work, as it includes NGOs. There are projects executed by international partners. So in this program we can track the contribution of all of the participants, which are the real executors. In this case, the next program is EMIO. This is online system for collection and analysis of indicators for monitoring and assessment of HIV programs in the country. In Kazakhstan, it's used since 2016. The electronic surveillance is also included, so it gives us certain results. We standardize the collection entry of data from different territories, and also in line with our norms, it's done twice a year, and also there are quarterly indicators, and in line we use that quarterly indicators for reporting. It is used in international reporting for UNAIDS report. I'm not going to give all of the details of this slide, but it's not used for the AIDS service, it's for mental health centers. So this is the center, the information for the replacement therapy. So this is the patient register for those who are on the replacement therapy, and we do continuous improvement of those systems, and also there are changes introduced into IT systems. The system that I mentioned, prevention of so the programs on prevention of the disease in key groups. So we are moving to from paper to electronic forms, and it will be integrated with the IT systems, existing IT systems. So the electronic monitoring system, which I mentioned, we will make it a cloud system. We plan to further improve the national register of population, and also there are plans to cover the whole of the Republic, and we plan to develop an IT system for pre-exposure prophylaxis, because we start its implementation, and the web service for PLWH to inform the partners about their partners on the need to make the test. Thank you. I tried to be quick. Thank you, Irina. Yes, that was a really interesting presentation. That's interesting to see the electronic databases, the progress which are used in many countries. I think that would be interesting to learn something new and try to introduce this practice in your countries. The next presentation will be done by Valentina Kirzhanova, National Research Center of Psychiatry and Narcology, named after Serbsky, of the Healthcare of Russia, Healthcare Minister of Russia, on narcological trends in Russia.
Добрый день, уважаемые коллеги. Мне хотелось бы...
So, good afternoon, dear colleagues. I would like to thank the organizers of this conference for inviting me to participate in this conference. And I listened to many presentations at different sessions, and that was a great pleasure for me, and that was very useful in my work. I would like to briefly speak about the modern trends in incidents of drug addiction in Russia, the Russian Federation. Over the past 10 years, in drug addiction has major changes because of the changes of the drug market. And based on the criminal data over the past 10 years in Russia, this so-called new psychoactive drugs became more popular compared to opioids and heroin, and their share is increasing every year. Of course, we also can see that indicators of medical care for drug addiction. So this is the primary data on mental diseases related to drug addiction and drug use in teenagers, young people of 18, 19, the population from 20 to 39, and the population group of 40-59. The primary incidence reflects the situation the best for the case, for this case. So the primary incidence, so its onset was in the end of 90s. After the year 2000, there is a decrease in most of the age groups, and the general indicators for all of the age groups. The only exception is 40 till 59 year group, and they had an increase compared to 2002 and 3, so there was an increase by 2.9 times, and the general trend over the 20 years, it's a decrease of primary incidence in all of the young people's group. The high decrease rate was seen in teenagers and the young people of the age of 18-19, and the primary consultations in the older groups is growing, and with the general decrease of incidence, so there is a growing age of the patients who come for narcological care for the first time.
The downward trend is also typical for injection-based drugs. Over the past 10 years, we see the twofold decrease in the incidence and twofold incidence in primary cases. Among patients taking injection drugs, we see a decreased share of younger people and also decreasing share of the patients above 45 years old. So again, we see we see a decreasing number of patients in the age of 45 years and up. Now let's look at the structure of drug dependency depend on the type of drug. So you see that if you look at this structure, the breakdown, the opioid dependency would be prevailing and would account for almost 90%. Today, the situation is drastically different, and we see that other types of dependencies are more prevailing. Among them are psychostimulators, cannabinoids, and other types of drugs and their combinations. The latter account for 37%, and the share of patients taking opioids has decreased from 86% to 28%, and the patients with opioid dependency used to make up the largest share of all patients taking addiction drugs, not any longer. The change in the age structure had its impact on the incidence indicators. So you see that opioid dependency goes sharply down, almost to historical minimum. At the same time, the dependency from cannabinoids, psychostimulators, and other types of drugs, including the new ones, would go up. As it is well known, people that take psychoactive components belong to the group of risk when it comes to getting infected with HIV or hepatitis. So all categories of drug abusers are tested for the above-mentioned drugs, and we do 100% testing for HIV and hepatitis, regardless of the outpatient or inpatient treatment. And here you see the share of those patients that underwent treatment, and these are patients with alcohol dependency, but of course a closer, more comprehensive examination is provided for the patients that use injection drugs. The latter, as a rule, are tested several times a year, typically twice a year, especially during repeat hospitalization. And we also have information about HIV infection among drug users. The highest level is observed among the categories that take injection drugs, and lower incidence is observed among patients that take other types of drugs. And finally, let's talk about the alcohol dependency. Despite the fact that HIV level of incidence is not high among alcohol abusers, still we see the upward trend, and that is worrisome. Here I provide for you dynamics about HIV infection among patients that receive narcological treatment in hospitals, and you see here an upward trend throughout the whole period of time. And here you also see the levels of HIV infections among patients taking injection drugs, and we can see that in 78 out of 85 regions we see 5% of all users being infected, and we see that the leaders here are Ural regions, Siberian regions, and these are the regions where drug abuse has a large prevalence and long history. And based on data from hospitals, we have high level of HIV infections, but I'm not going to dwell on that due to lack of time. What can I say about hepatitis C? The highest incidence level is observed among drug users. They are marked here with red lines. So we are talking about consumers taking injection drugs and other types of drugs. Secondly, second go the patients that take various psychotropic agents, and The third ranked the patients with alcohol abuse, and these are stable indicators of the past 10 years. The highest share of infection rate is observed among the injection drug users in 45 out of 85 regions. We have drug abusers infected with hepatitis C, and again, the worst statistics is observed in central Urals, Far Eastern regions. So we can say that the incidence of hepatitis C is high throughout the country. The level of incidence with hepatitis B among drug users is not high, especially compared to hepatitis C, and in different diagnostic categories it accounts between 2 to 6%, the highest levels observed among drug users and namely users of injection drugs. And finally, I would like to say a few words about the impact of COVID-19. Namely, it has decreased the number of doctor visits, so we can say that the primary incidence went down by 22%, and general incidence went down by 7%. The number of visits decreased by 14% visits to doctors, and the number of hospitalizations went down by 19%. And I will make conclusions of the past years. We see a decrease in the share of young people and teenagers, but we see an increasing number of patients over 40 years of age. We see the decreasing number of patients with opioid dependency, and but we see the great dependency on new so-called designer doctors, and the growth of infection rate for other comorbidities is highest among injection drug users. We see high level of positive tests among among the drug injection users. With this, I will finish, and thank you very much for your attention. Thank you, Valentina Vasilyevna. And now I would like to the floor to Evgenia Ivanovna Kazakova, a research fellow, Research Institute of Virology, Republican Center of Epidemiology, Microbiology, and Infectious Diseases from Republic of Uzbekistan. She will talk about viral characteristics of HIV-1 in Uzbekistan. Hello. Yes, hello. The floor is yours. Can you hear me well? Yes, we can hear you well. So, hello, dear colleagues. It's a pleasure to participate in this conference. Although I participate online, it's a pleasure to see familiar faces. And I will talk about viral characteristics of HIV-1 in the Republic of Uzbekistan. I will start from RISIDA project that allowed us to describe HIV-1 circulated strain in Uzbekistan. The project aiming at preventing the spread of this resistant strain also enjoys participation of Russian Federation, Armenia, Belarus, Azerbaijan, Kyrgyzstan, Tajikistan, and Uzbekistan. This is the second similar project being run at the moment, and this is a project that provides large-scale monitoring across the countries. And we already are holding the third monitoring across the country. As of 2016, we started doing the sequencing of HIV-1 because we have a department at one of the municipal hospitals for the patients that do not take intraretroviral therapy, but we did not, prior to that, carry out high-level surveys due to high costs, but together with UNAIDS, we ran the project, started doing it in 2014, and then in 2017 we launched the project called RISIDA, and currently we are implementing the project RISIDA 2. I would like to thank Rospotrebnadzor that is really helpful in holding this surveys. It holds trains all types of working meetings and consulting with experts. Here you see Natalia Nikolaevna Ladna, who is one of the coordinators on the part of Rospotrebnadzor. Thank you very much for providing support to us. And also, as for the support received from Rospotrebnadzor, it was given in the form of equipment, disposable materials, equipment for the lab that helped us to stay afloat. This work was done for a long period of time, so we have developed protocols similar to WHO protocols. We have already developed and approved the second version of national protocols for the Republic of Uzbekistan, and also at our scientific facility we are monitoring several components. So we are monitoring resistance among adult patients that start taking antiretroviral therapy, and we also are following up patients that have been receiving the therapy for 9 to 15 months. And we, as I said, are continuing our project RISIDA 2 dedicated to cross-sectional resistance of HIV infection to treatment. So we do genotyping procedure, and we're looking at protease and reverse transcriptase. As for the incidence of medical resistance, it is quite high worldwide, but Uzbekistan started therapy not long ago, so we've been practicing antiretroviral therapy for 20 years only. Therefore, we don't have such high statistics as in countries that offered these types of therapy to their patients much earlier. We are talking about Northern Europe and Northern America and Western Europe, but we still observed several cases of mutations. So here you see data from 2015. It was a mutual project together with UNAIDS. So you saw that the initial medical resistance of HIV accounted for 2.7%. However, the patients that received treatment and demonstrated resistance, the spectrum of mutation was about 60%. So one should say that the first study included 850 patients with HIV. Residar included 714 patients from all regions of our country, and 40% of patients were naive, and while others had taken ART previously. And since we changed the tactic of our recruitment, initially we took patients that and doctors that were recommended by doctors. Then in the second study, we engaged in the all patients that started antiretroviral therapy. So we can say that 80% of over 80% of patients demonstrated suppressed viral load. That is a really very good result. However, as we assessed our results, we saw a certain increase in medicinal resistance, and the percentage was 4.8, what is lower than the threshold. However, still the growth was observed. If you look at the mutation spectrum, it has not changed. Among patients that demonstrated no response to therapy, 69% demonstrated resistance, and it's not a bad indicator, because we saw that commitment to treatment is quite high among such patients, and the level of mutation was also similar. Also, we tried to introduce the quality control for sequencing, so we did sequencing of 2 panels. We used the WHO approach, and unfortunately, we don't have enough samples in order to get full quality control. So far we are working this way. And now let me tell you a few words about the genetic types. HIV circulates on the territory of Kyrgyzstan. These comparative data are between 2018 and 19, so we can see the peak of the genotype landscape. In 2015, we saw over 50% of patients that had 0.28G form, while 37% of patients had A6 type. And we also saw some minor versions. However, in 2019, A6 subtype was ranked first, so 48.5% would have that type, and the share of circulating recombinant form AG2 went down, and also we saw a large number of recombinant norms, what is quite typical for the Republic of Uzbekistan and former CIS countries. So in Uzbekistan, we have quite interesting picture when it comes to HIV subtypes, because in our country we have two different types circulating, that is subtype 06 and 02HG, and if the patient is infected with two strains, or if we have repeat infections, we see unique recombinant forms, and they provide us with such interesting statistics. So we can say that in Uzbekistan we have heterogenic population of H102HG circulates here, that is typical for Central Asia region, and A6 that is typical for the Russian Federation is popular here as well as a subtype. So we can say that 48% of the population accounts for A6, and 40.3% account for 02AG, and there are 9% of recombinant forms. The results of the past studies are not finalized yet, and hopefully next time we will be able to produce your more detailed data, and it will be relevant for you. Thank you very much for your attention. And this is the last news from us. We finally have published our article, so now you will be able to find lots of statistics on our country. Thank you very much for your statistics. Thank you, Evgenia Ivanovna. It was very interesting, and I think that it will be this data will be relevant for comparison, and I know that this report will be recorded, and then it will be interesting to compare data. Now I would like to give the floor to Anastasia Pokrovskaya, who will talk about the social democratic profile of people living with AIDS in our region. So the floor is given to Anastasia Pokrovskaya. So I welcome all the participants that joined us online or offline. I would like to provide you with results of a large cross-border study that took place in the 7 countries that you see on slide, and it was provided with support of Rospotrebnadzor, and many colleagues that participated in that project are here with us today, and I'm very happy about that. Well, I will dwell on the area of interest for us. For us, the goal was to create the social demographic profile of our patient, and the idea behind was to create social demographic and clinical laboratory portrait profile of the patient that receives medical aid related to HIV infection. And we understand that we are different countries, however, and the ways for pandemic spread can be different as well. So patients may have different needs, and it's important to understand what kind of patients receive aid, who do not, and who we should focus on. Here, I'm not going to give you detailed description. The survey took place for 3 years or so, and we were able to include over 12,000 patients into this study. The number of patients per country were calculated depending on the number of HIV positive people, and of course here the figures would differ substantially. So we collected standard information from medical documents, and we also looked at social data on the patients, their marital status, the number of children, if any, that they had, and other types of information that we could collect on the patient. All in all, you can see we have collected or have developed almost 70 indicators, and I will dwell on something what is of particular interest. As it was said during previous presentations, the main category of patients are men, as you can see here. So the first bar stands for man, and the second for women, and second for men. And we know that those who receive medical aid and are ready to participate in surveys are women, and therefore the higher proportion here are women. Another important point we paid attention to.
So it is in line with the general information about this data. So the women were younger in the study, and about men, we know that in our region. In women we find it earlier. On one hand, they are infected at earlier age. On the other hand, they are detected earlier compared to men because they have more access to medical services. And the difference between men and women, and here for men and women, this is the total for the 7 countries. And the compliance was better for women compared to men. If we look at the split by country, so this is the same for all of the countries. And for Belarus, men had better indicators, better results for compliance, but it can be due to different reasons, because women also were prescribed medication because of vertical transmission risks. And after thinking about this, we understood that was not gender related, but it was related to other social factors. And also related to differences in behavior between men and women. These are the main transmission and infection ways. So mainly in our country, these are the drug users, and in our region, most of them are men. If we look at the people in the study, those were mostly people with sexual transmission. Unfortunately, we can conclude that the drug users are less covered compared to those with the sexual transmission. If we look at the responses about oral drugs over the past 6 months in some of these countries, so there were many such people, and we can say that drug consumption is no impediment to get medical care, but still this is a risk group for further transmission of HIV infection if these patients are not on the treatment actively, they are not getting it. Another thing that we noticed and which may have a potential impact on compliance and accessibility is the labor status. Most of our patients, they work, they continue to be active members of the society, and there was interesting group people who mentioned that they work in another country, not in the country of their origin. So these are labor migrants. It varies from country to country. In Tajikistan, Uzbekistan, and Armenia, there was a big share of people that mentioned this type of labor activity, and we understand that there are much more such people because they have limited access to medical services in their country, and when they are abroad, so they cannot always get treatment for HIV, and also for accessibility and risks of transmission of infection. So this important group, most labor migrants are men, which is also reflected in those indicators that we can see here in terms of coverage of men and women with medical services. The marital status we also assessed it. As for epidemiology, premarital relations, well, they are not always mentioned, and they do not always speak about the real sexual behavior that is important to us. So we pay attention to the number of sexual partners, especially relations that our patients have. We saw that there are lots of people who mentioned they had more than one sexual partner over the past 6 months. So potentially they may be in the group of in the risk group. And also among those who mentioned that they have a constant sexual partner, only 1/3 of them had HIV-infected partners, and many mentioned that their sexual partner has no HIV, and here no data is in gray, so they don't know about the status. So and also we need to just involve partners to be tested. We cannot earlier make prevention or treatment because non-infected and partners and also partners with no status, they can have a major impact on the infection rates. Well, children, so this is the participation in demography. Most patients, we understand that our patients are quite young and they already had children, may have children in the future. As for the country's indicators, and in some children, we have 4 more children. And what is the most important detail for us, if we look not at the number of children but number of births that women mentioned before the diagnosis of HIV and after the diagnosis. So most children were born by women before HIV diagnosis. We cannot say that it was due to HIV. I mean, the decision not to have more children, maybe they just already have enough. Anyway, they were not planning them. And the young women, they were just under 35. Maybe they were going to plan to have more children. But that is actually the trend that we saw, the reproductive trend. Well, summarizing today's presentation, what we can say about the results of our studies. So women compared to men in the countries that we studied have higher compliance to follow-up and treatment. They had higher efficacy of treatment, and we should pay more attention to the patients for men, especially who use injection drugs, as they may be limited in terms of access to medical care due to different reasons, and also migration processes and account for a big share of our patients. Many of them participate in migration. It can have an impact on transmission of HIV, on accessibility of medical care for these groups. And patients who are followed up in medical institutions, who have access to medical care, they preserve their social functions, they participate in labor activities and demographic activities, and of course we should just try and also support their quality of life and prolong it. And possibly HIV has a negative impact on reproductive choice of women, and because of that we should also pay special attention to that, and we should remember that many of our patients, they have HIV negative and with a known HIV status, and we should also pay attention to that. We should provide consultation to the patients and to their partners, and also we should start ART with preventative goals in these groups of patients. Thank you for your attention. Thank you very much, Anastasia. Thank you for such an interesting study. Next presentation will be done by Aygul Salpueva, head of Department of Immunology of the Republic Aid Center of Kyrgyzstan, experience of HIV rapid testing systems in Kyrgyzstan. So good afternoon, dear colleagues, dear participants of the conference. I would like to thank the organizers of the conference for the invitation. I'm very happy I am here at this conference, and I would like to share the experience of rapid testing, HIV rapid testing in Kyrgyzstan. And I would like to speak about the assumptions and to introduce the rapid testing and what were the reasons, what were the learnings, and what were the next steps. So in the first place, we're talking about the recommendations of the European WHO mission. That was in April 2011, our Republic. There was assessment of the state program for HIV/AIDS in our country and other activities aimed at fight against the pandemic in our country. And they made several comments, and we used two major recommendations. First, to develop and suggest amendments to the legal and to the norms and regulations, and also allow for NGO participations and HIV testing and consultations and preparation of specialists in line with the rules for consultations and testing by their certification. And so consider the participation of non-medical staff and public society in provision of services for testing and consultation on HIV, so that we can foster rapid testing, rapid HIV testing. And also first we analyzed coverage of HIV testing from 2008 till 2010, and also by ways of transmission. So according to HIV testing coverage, so we found out that we did over 400,000 tests per year, and among them the share of key groups was very small. and who were tested: pregnant women, medical workers, which is obligatory, and military people, labor migrants when they need the health certificate, and other groups of population. The share of key population group was less than 1%. And also, when we analyzed the new cases of HIV, we had about 60% of new cases coming from the key groups. Sex workers, people use injection drugs, and men practice sex with men. And also in 57% of cases that was oral, that was the injection drugs. And you see that in 2008, 9, and 10, you see the shares of these key groups in the total amount of people tested, less than 1%. Introduction of rapid tests for HIV in NGOs. That was the solution to this problem. I would like to speak about advantages of rapid tests. Quick access to test results, and also when we introduced that practice in NGOs, we gave access through these organizations to vulnerable groups, key population groups, because at their own will they do not wish to come to a medical institution to be tested. And also consultation before and after tests to these key groups of population in the environment where they are getting their services, customer-oriented environment in NGOs. The rapid test for HIV in NGO helped us to decrease the workload for the AIDS labs.
Постановки экспресс-теста по околодистевой жидкости.
And also the technique is very simple.
Очень удобно в использовании человеку, который...
It's very easy to use for the person who's providing the service, and it's very easy for the person who gets the test done. Well, how we implemented the rapid test in 2012, based on these recommendations, we decided to introduce rapid tests in 12 centers. 12 centers, LGO, so they work with these three key groups: sex workers, men having sex with men, and people who consume injection drugs. And 3 organizations, they work with sex workers, and 3 with men having sex with men, and 6 working with drug users of injection drugs. And we also took into account that in case of positive result, so this result should be proved in 8 centers.
Тренинги трехдневные именно сотрудников.
And
сотрудников Центра СПИД для того.
And also we provided for interaction between NGOs and 8 centers. And 6 months after introduction, we made an assessment of the program. And as of this assessment, it was decided to expand the rapid test system. And in 2013, by the decree of the Healthcare Ministry, there was the official permission given to introduce the tests in 21 NGO. 21 NGO, they are working. They have their own websites, around 27, 28 websites, and in 2013. And also we introduced that type of rapid tests in prison. So, and if this liver test is positive, so then the blood assay is done, and it's done this test in the AIDS center. We also developed the forms of reports to understand what will be the next actions, next steps. That was pilot. In the beginning, when we introduced the test at the NGOs, so that the customers, they get used to that, there was a reward, mobile units. So for the mobile cards, maybe because of that, many customers could get the secondary tests in NGOs and even the NPO clients, which were positive, even under ART, undergoing NRT. Because of the rewards, they also could take the test. And also, we did not fully develop the mechanism of follow-up for those with positive results. So in the beginning of the project, we would lose the clients. Not everybody agreed to get the support, and they were recommended to go to AIDS centers to prove their positive results. And they had some problems in the beginning, and also there were cases of unquality consultations, and maybe sometimes you know the express tests were not done properly and the results were false. And then we took into account all of these details, and at a regular basis we do monitoring with our partners. The rapid HIV tests are currently done.
Вот, как я сказала, 21 НПО, это
By 21 NGOs, so these are different projects. Pew site, that was the flagship. Now the EPID program on ICAP website, we do rapid tests in mobile stations in faraway regions of the Republic. At the same time for syphilis and the hepatitis B and C.
до сих пор продолжается.
Here on the slides, you see the results of express testing on NGO-based. That is something that is funded by the Global Fund. And here you can see the statistics from 2016 to 2020. And here you see the positive results as absolute number. And these are the newly identified cases. Here you see the express testing based by NGO projects within the Flagman project, and again statistics for the same period. And here you can see that Flagman project provided the greatest number of new HIV infections because they had different approach to testing. And as I said, case management here was very thorough because new clients were tested, and case management was so good and efficient that measures that would follow up the positive patients, they would not have any motivational any incentive bonus until the patient would get viral suppression. This is the express testing with GSAN facilities. These are the express tests that were done within ICAP projects. They did testing based on capillary blood and mucus. And here you see the new cases of HIV infections based on risk groups. I would like to show you that we still see new registered cases among the key groups of society, and thanks to the introduction of express tested within NGO groups as of 2019, we were able to find an approach to one group, precisely men practicing sex with men. And in the absolute numbers, you see that before 2019, we had very few cases of HIV infection registered within that category, and from 2019 the identification rate went upward, and thanks to introducing this program, we have enjoyed considerable success. And as for epidemiological situation for HIV, the situation is the following. As of January 1st, 2021, we have carried out cascade. Unfortunately, our country was not able to achieve 90-90-90 goals, and we have what we have. And as for our subsequent steps, we have taken some lessons learned once we have introduced the system and regular monitoring. So we will continue express testing with mandatory monitoring on the part of Republican AIDS Center. That will be done together with our partners. So we will continue express testing with engagement of NGOs, and we also will do it with the use of the mobile unit, and we will also do express testing at locations with the high traffic of people during some special events, and we will extend express testing in medical facilities. And in March 2021, we held trainings for nurses in hospitals, so they would be capable to test patients based on clinical indications, especially in those locations where there are no immediate access to labs. And we will also encourage self-testing among discordant couples, and we will assist testing against the background of COVID. And we also continue index testing, and we will introduce assistant testing for NGOs, and we will continue regular education for medical professionals, for NGO workers, and we will also offer so-called refresh trainings. Thank you very much for your attention. I was really in a rush. Well, thank you very much. Thank you for this interesting report. And now I would like to give the floor to Olga Pantilevna, Head, Department of Epidemiology and Medical Statistics from St. Petersburg HIV, AIDS and Infectious Diseases Center. She will talk about HIV epidemiological situation in St. Petersburg.
Здравствуйте, уважаемые коллеги.
Hello, dear colleagues. Allow me to share with you our achievements and our plans for the future. St. Petersburg is one of the regions that counteracted HIV infection among one of the first, and only since 2013 St. Pete is not among top 20 cities in terms of incidence, and up to that we were among top 20. Well, as for 2020 or 2021, we will again improve our rating, and we hope that the situation will continue improving. As of 2012, we have better statistics than that the average of Russia. As of 2006, we see a downward trend in terms of detecting new cases, although that in absolute numbers statistics is still quite high. You can see that on the slide. Regularly we identify 2,000 cases on our territory. That includes permanent citizens and visitors. And generally we identify 15 to 17 cases among children, and this is explained by different ways of getting infection, but that all happens against the increasing number of the patients that undergo testing. The only difference was in 2020 when we had to impose restrictions in terms of visits to outpatient clinics. So the number of examined people in 2020 went down, and that includes local and foreign citizens. So the coverage overall in the last year went down. If you look at the trend, we've been tracking it for a long time, and despite we believe that the overall trend goes down, and annually we identify fewer and fewer cases. We are still concerned about a high number of people that are not permanent residents of our city. In 2020, we had 42% among all patients who were foreigners. It's a large indicator, I believe, one of the largest in the Russian Federation. If we look at the incidence dynamics and do the breakdown for the age groups, we should say that over the past 5 years, we see improving statistics for all age groups. It is important to say that the incidence is higher among older people of older age, and maximum incidence would fall on the age group between 40 to 49 years. If you look at this graph, you will see that the incidence is prevalent among men, except for the age group of 20 to 24 years. And here the highest incidence is between the age of 30 to 45 years. With women, the statistics is more homogeneous, and there is not huge difference from one age group to the other. If you look again at the statistics, you will see that overall we have twice as many male patients that have a positive HIV infection than women, and women have higher incidence in the younger age group between 25 to 39 years. Again, here you see the same statistics but shown graphically. So the last year showed better statistics than the previous one, and we can say that most of HIV-infected people that live in our city belong to the age group of 35 to 50 years. If we look at ways of transmission, we see two typical trends. And if in 1999 the dominant way of transmission was parental. Then it became from 2013 sexual way of transmission became dominant, and something what was quite typical. But now in 2020 again the trend changes. Parental becomes more popular, and sexual transmission on the contrary goes down. So in 2020, if you look at absolute figures and structures and ways of identification, I think here the statistics is in line for the line with the average across the country, but we have two rare ways of transmissions, and that is the infection or transmission of infection to infants during breastfeeding, and also transmitting infection to children that did not have any sexual contact. So surprising, but something we have to pay attention to. We have a large number of HIV positive people that are registered and that receive antiretroviral therapy. If you look at the coverage of the letter for the past year, the coverage was high, and it was equal to 68.7%. So if you look at our performance, important is to say that we have a decrease in number of lethal outcomes, and in that regard 2 years show positive dynamics, and despite all changes and pandemic, we see steady increase in the number of lethal outcomes caused by AIDS or development of HIV infection. We believe that the largest impact is provided by continuous antiretroviral therapy that shows high level of efficiency. And as for lethal outcomes, we know that 24% that die in our region, they are not registered and are not followed up. Therefore, they are not treated, and they are not citizens of our region. That's why they probably are reluctant to seek medical aid. So we believe that overall the situation in our city is quite good. If we were the leaders in terms of the number of identified cases, we reversed the statistics, and we have steady increase over a long period of time, and we are talking about 5-year period of time. And out of problems that we have identified for ourselves, coronavirus infection in this regard does not count, because we believe that it does not have large impact on all processes that are taking place. So there are 3 core problems, and that is a large load on AIDS center, After all, again, 42% of newly registered cases are not citizens of St. Pete, and 51% of patients that approached us were citizens of other regions, and they were monitored in different regions previously. Another big problem,
and it caused lots of concern. So this is the share of the transmission way through injections, and also it is connected with the high inflow of people from other regions with higher rates of drug users, and also HIV can be transmitted through breastfeeding and family transmission. And so it's these are the cases of the places of residence where there are people who are not treated with ART. Thank you for your attention, dear colleagues. I tried to make it as fast as I could. Thank you very much, Olga. Well, as the last speaker did not appear, we may say that we practically finished on time. If somebody has some questions, so 1 or 2 minutes we do have for Q&A. As far as I understand, there are no questions. I'd like to thank all of the speakers. Yes. I would like to still ask one question to Kyrgyzstan. This is very relevant about rapid test system. Why you have such low level of incidence during the express test? I did not understand about the groups, but you showed one big group, 20,000 tests, and 0.1 HIV infections you found. So what is the share of all what is the share of rapid tests in the total number of HIV tests? Sometimes the routine tests, well, the share of new cases and less than 1% of all of the people tested in the Republic. What you say among the tested in the NGOs, right? You ask about that. Yes, in the beginning, we had quite good indicators, but starting from the year 2013, we see that we have like 20,000 and so on, and these are the numbers of tests, and incidence is smaller. Maybe we've identified all of them, but among sex workers, we also witnessed that, and among men having sex with men, I would think that sex workers, they're in the general group of the population, but not everyone can accept that they are doing sex work. And despite the big number of tested, even in the NGOs, among them, so the share is small, their share is small, and also, and I think this type of rapid test gave us access to key groups of the population, and they have this compliance to testing. They started to get used to regular tests, and despite having less and less new cases, and we think this is also an achievement. They know that you should get the test, and they get these prevention services, prevention treatment. It's like stimulation. The share is like small. Yes, those who did the test with the rapid test. In 2016, among the new cases, we had the biggest number. It was 30% of the total number was among the key groups of population for the flagship or flagman project. They had a different approach to that. That's it. Thank you very much. Thank you. I would like to thank all of the speakers for exciting presentations, for sticking to your timing. That is very nice. I hope that we will have time to have a cup of tea. I would like to wish you fruitful work in 2021 and in the next years in terms of prevention of HIV and in terms of achievement of the ambitious goals set by UNAIDS for the next future. And I hope that that's going to be our overall goal, and we'll do all we can to deliver that. Thank you.
Поздрав России. Наоборот. Я умею ходить.